So Steve, why don't you introduce our baby briefly? This is technically a commercial before the educational content begins. So go
Yes.
ahead, I'll give it to you while I'm taking care of a technical thing here.
Hello. I'm assuming that I have this in frame.
Yes, you have it in frame.
So, good morning, good afternoon, good late afternoon, good evening. Not sure what Norway is at this point. Yeah, I would say probably early evening. So, this is our book, Healing Addiction with EMDR Therapy, a trauma-focused guide. And it is now, I would call this the fourth book that we have worked on together.
It is our fourth child.
And that's what we're going to be focusing on today. And the thing that we love about this book, Jamie and I, is that we've been working on this project of healing addiction with EMDR therapy for many years, and we did our best, and I think we did pretty well at putting it all in here. So we're really excited to be with you here today. Really excited about those of you who already have the book. Hoping that some of you might be encouraged to buy the book and use the book by spending time with us today. So
Great.
Really glad you're here.
Really glad you're here. Hi, Tom. I know Tom's on lunch break. He's doing a training this weekend. Tom's a ICM, Institute for Creative Mindfulness, our company trainer. Paula, hello, joining us from Raleigh, North Carolina. So let's officially start the webinar.
All right.
Thank you to those of you who are here in real time. So good morning, good afternoon, good evening. I am Dr. Jamie Marich, the founder and director of the Institute for Creative Mindfulness, and this is my writing partner, my ice dance partner, my collaborative faculty. We have just a lot of different roles at this point.
Yes.
So this is Dr. Steve Dansiger from here in Los Angeles, California, where we are doing the workshop this morning. So the live version of this is a 3-hour webinar. It will be available at a later date for recording. So if you're watching on the recording, please know that your presence is here with us in spirit this morning as we launch the content. And the official title of the workshop this morning is The Standard Protocol in the Treatment of Addiction. And after we do a little bit of our opening welcome and centering and grounding, we will explain why we feel it is important to do a webinar of that title. Steve and I have written 4 books together, the first of which is help me with the exact title here.
EMDR Therapy and Mindfulness for Trauma-Focused Care.
And our most current book is Healing Addiction with EMDR Therapy, a trauma-focused guide. Sometimes it's hard to know where all the words fit in one place. And we've also done together 2 recovery resources, 12-step trauma-informed meditation reader and workbook. And even though this webinar is not a direct rehash commercial of the book, we are going to be really emphasizing one of the key points of our newest book, which is that in so many presentations that baffle us with EMDR therapy and addiction and compulsions, the standard protocol is really much of what you need. So more on that after Steve gives us a little introduction and grounding and centering here, because mindfulness is our jam, as evidenced by the fact our training program is called the Institute for Creative Mindfulness.
One would think.
And one of our real driving points here is that may mindfulness be at the center of all that we do in EMDR. So Steven, I will turn it over to you.
So welcome everyone. And we'd like to start with a brief grounding. And when I say brief, probably about 5 minutes. And in that 5 minutes, I'm going to be giving you some invitations. And one of the things I'll tell you is that ever since the quarantine started and we went into this mode that we're in, I've been running a nightly meditation, and I've been giving the same instructions every night because in these times, it seemed to me that the more stability and sort of ongoing regularity of anything was helpful in sort of staying present. And so, that's at the macro level, and then at the micro level, we're going to spend 3 hours together. So let's ground. And so first thing, trauma-informed mindfulness instruction always includes, as far as I'm concerned and we're concerned, invitations, not commands. And one of those invitations is, if you want to keep your eyes open when you're meditating, doing mindfulness, please keep your eyes open. Open or closed is fine. A lot of times in mindfulness, you hear just close your eyes, and we invite you to keep them open or closed. And then when I ask you to take a posture that's sustainable for 5 minutes, that means any posture that's sustainable for you for 5 minutes. And so in this meditation, I'm just going to literally just check in on grounding points, points of contact, wherever you are and whatever your posture is right now. And then I might invite you to just take a moment, if you want to check in with the breath as well. And again, both of them are invitations. If you'd rather just hang out and do a loving kindness meditation or something else while we're spending this 5 minutes together, have at it. So that all being said, will we go with a bell, or?
Let's go with the bell. I love it.
Okay. Hoping that it doesn't sound like a dull clink. Let's see how Zoom behaves. So settling into our posture. And first, noticing points of contact. If your back is against the surface, noticing that. If you're sitting in a chair or on a couch, noticing contact in the seat, the backs of the legs, the feet on the floor. If you're sitting cross-legged, noticing contact leg to leg, ankle to ankle, foot to foot, and also leg, ankle, foot to floor. If you're lying down, noticing all those points of contact. And regardless of the posture, noticing also contact where the hands rest. And taking a moment to notice if any one or more of these points of contact represent a sense of ground or grounding for you today. And this might be noticed like a sense of rest or a sense of strength, something you can lean into. Or you might just describe it as ground or grounding. And if you have this sense of rest or strength or ground, go ahead and let yourself have that. And if the sense is more like, I don't feel so grounded today, see if you can notice that with as little judgment as possible. And either way, sitting in this way for a minute or so. And now inviting you to continue with this body and ground practice. And if you like, inviting you to take some or all of your awareness to the physical sensation of the breath. That can be done just outside or just inside the nostrils, or it might be done at the point of the rise and the falling of the chest, or the rising and the falling of the belly. Any one of these is a great place to just track or just notice the breath. Perhaps just choosing one for the length of this brief meditation. And this allows us to notice when I'm breathing in, I know I'm breathing in. When I'm breathing out, I know I'm breathing out. Sitting in this way for a minute or so. And at the sound of the bell, whatever your body wants or needs to do after a period of sitting.
Thank you, my friend.
Thank you.
Ooh. Something I like about your meditation style facilitating, and I know it has shown up in especially our first book together, is when you find your ground, let yourself have that. Can you explain a little bit of the inspiration behind that directive?
Well,
or invitation, I should say?
It's it's basically taking what is often delivered as sort of like, do this, go ahead and let yourself have it, which when a person is not feeling like they have that ground can be very confusing and actually distressing.
Right.
But as an invitation, it's an invitation
For sure.
to have what you want, what you already have, to have what you already have. And then the second part of the instruction of if you don't have it, that's okay too. That's the key.
So if you'd like to take some time to respond, if you're here live with us, about this question we ask in EMDR, what are you noticing now? If you respond in the comments, I won't necessarily read your name, but I may read some of them on the air just so we can hear the variety of responses. Because something Steve and I emphasize throughout our work is that when you teach these mindfulness skills, especially in phase 2, that needs to be the training ground for people hearing that question. What are you noticing now? What are you getting now? And if people give you answers like, well, I don't know, or, all right, help them unpack a little bit of it using the pleasant, unpleasant, neutral, the kind of feeling tone. What are some other ways you might respond if a person says, well, I don't know what I'm noticing now?
Well, just going back to your original concept, that what we're doing is we're training noticers.
Ooh,
right?
Yeah.
Like that Shapiro used that language because mindfulness was actually on her mind. And so and this is a theme that Jamie and I hit all the time, and we're going to hit today, is the more that we do in preparation, the more likely it is that the person that we're working with is going to know what we mean when we say, what are you noticing now? When we get to reprocessing, having taught them how to notice, having put myself out of frame there.
That's okay. And this is kind of a bridge from our previous work to the current work, because in EMDR Therapy and Mindfulness, we do go over some of these best practices for trauma focusing or trauma informing meditation strategies. Because yes, I am the first to admit just walloping people with too much mindfulness practice and too much noticing practice right away can be too much. for sure. So, how do we help deliver the practices in baby steps, in small doses, where a person can build up to becoming a noticer? And Steve already emphasized one of our best practices, which is the eyes can be closed or the eyes can be open. Something else he did in that meditation that I really like and we emphasize is if you're going to leave people in silence, let them know how long you're going to be leaving them in silence. Like at one of the points in the meditation, Steve said for about a minute. I'll lead you here. He also did an amazing job of really setting up the grounding before going into the silence, or if you're doing a breath meditation. It's important to remember that breath can be overwhelming for people who haven't really sat silently with their breath yet. So, yes. So, one of the responses we got when I asked, "What are you noticing now?" Less tension in my arms, able to feel calm and less restless. Another comment is a therapist friend of mine who does proprioception bodywork says, try to bring your attention and not your intention, observe without judgment. Yeah, and that's one of the working definitions of mindfulness is how to observe without judgment. And even this is a nice kind of segue to what we're talking about, the standard protocol here. When Shapiro says, go with that, often I'll ask new trainees, especially when they see a first demo, what does go with that seem to mean to you? And for me, a good definition of go with that is just keep observing without judgment, right? Mm-hmm. And Steve highlighted a point that we really get into more in our first book, which is that Dr. Shapiro had an active mindfulness meditation practice. That was the container in which she made this discovery that led to what we now call EMDR therapy. And my interpretation of the history and knowing kind of the development of EMDR is she did downplay that for a lot of years. She didn't deny it. If you read her books and the background, she credits Stephen Levine as one of her meditation teachers. But I think it did largely get downplayed because there was such an emphasis on making sure EMDR got the evidence base, the research, the numbers really backing it. And some of these mindful components, kind of got downplayed a bit, some of the more meditative components. And Steve and I have long felt since we started out on this work together that now that EMDR's efficacy has really been established, let's go back to some of those roots and bring those out in how we teach EMDR.
And I love one of the ways that we were able to kind of unearth the whys and wherefores as to why she kept it under wraps is the fact that in the mid 80s, late 80s, when she developed the therapy, if you look at the clinical literature, you will find approximately 1 or 2 articles on mindfulness in the clinical literature per year. It doesn't increase to like double digits until in the 90s. And so already there she was saying, hey, if you just do this, you're going to feel better. Mm-hmm. That's already strike one in terms of people giving her a hard time. And,
for sure.
And then, if she had added mindfulness, which at that point was not seen as something that we're doing together for therapeutic purposes.
And for sure, I mean, we're now in an era where there's at least 500 clinical studies on mindfulness published a year. If you're interested in more of that, grounding in literature, I highly recommend The Greater Good at UC Berkeley as your go-to website for looking at the collection of mindfulness research, just like you might look at the Francine Shapiro Library for the collection of EMDR research. So one more comment here that I'll share, because I really think there's a lot to bring out here. I was able to notice that I had a hard time sitting without judgment. Welcome to the human experience. Which was a new experience. I immediately relaxed and made it easy to continue. And I have found that sometimes when we name the difficulty, then what happens?
Bye-bye. Because now I'm in mindfulness of the difficulty rather than in the difficulty. Mm-hmm. And we do a lot of teaching around that, around the 5 hindrances to mindfulness practice, and using those hindrances as first portals into practice. And Angelica is pointing out one of those hindrances, mm-hmm. which is kind of a combination of doubt and restlessness.
Yes, indeed. So just to kind of throw it out there right now, since you went there, the 5 hindrances are.
So they are this, and again, this is not like these are bad. these are hindrances to our practice. The first is sense desires, right? Just, all the stuff of the five senses. And again, not being like, oh, sense is bad, but, takes us away, right? Takes us into monkey mind with it. The second one is ill will, right? So sometimes translated as anger, but really more accurately as hatred, right? Sort of along those lines. And then third is sloth and torpor.
Love that word, torpor.
Just gotta love the torpor. And then there's restlessness and worry. And lastly, there is doubt. And so oftentimes when I'm working with a new mindfulness practitioner, that is where we start, because that's where they are, right? That's where I was when I first started meditating. And I go back there all the time. Why? Because I'm a human being, to your point from earlier, right? The human experience. And so my first step into mindfulness often is, I am now mindful that I am in ill will. I am now mindful that I am in sloth and torpor, because I love saying that word.
Torpor is an amazing word.
It's a great word.
And just as a little clinical tip we can both give you, because I know we have all had clients say things like, I can't meditate, I can't sit still, I'm restless, my mind's always going, et cetera, et cetera. And usually how I meet that is, okay, neither can I. Most days. I really think as effective human EMDR therapists, we have to validate a lot of those hindrances, a lot of those doubts, a lot of those judgments, because I've had them, you've had them, and we both have pretty extensive practices. And I think that helps create an avenue for a greater sense of reality and connection in your therapeutic relationship, a greater sense of openness about not judging the judgment. As opposed to, it didn't go as planned. No. And then we get questions from our consultees like, it didn't work. What do I do? And often I will say, just start by normalizing it. When people say, welcome to the human experience has become my favorite. Yeah. It's one of my favorite lines. And one of my dear friends I won't go into his whole backstory, but as he struggled with recovery, he used to say things like, I'm just such a negative person. And, this is what's keeping me stuck, because I'm always dwelling on the negative. I'm always dwelling on the negative. And he found that he was somehow uniquely horrible because of that. And my suggestion for him was, or not suggestion, but my comment to that was, welcome to the human experience. Because even the Aip model that underpins EMDR gives some language to validate this idea that the human brain is designed to kind of gravitate towards the negative, and it takes health and healing and validation, and in the case of EMDR processing, to link it up with those positives. So well, again, those of you who are here in real time with us, welcome. It's kind of like you're joining us for our Sunday coffee. This is a pretty chill webinar experience this morning, and also greetings again to those of you who are joining us on the recording. So before we really unpack this idea of why the standard protocol in the treatment of addiction, I'd like Steve and I to give you a little bit of our backstories here. I mean, I know you kind of get these from presenters every time you come to a webinar, but in the case of doing a webinar on content that is connected to addiction, I do think it's important that you hear a little bit of our journeys to get here, because Steve and I are both individuals in long-term recovery. We are both phenomenal EMDR enthusiasts in terms of really believing it and using it and teaching it. And one of the reasons we really connected as friends is this understanding that the two go together very well. So Steve, why don't you give a little bit of your mini qualification, and then I'll follow suit.
All right then. So hi, I'm Steve, and I'm not gonna.
Hi, Steve. You can do that. I'm Jamie, and I'm an alcoholic, an addict, etc., in long-term recovery.
And that being said, I know that there's many different feelings about why people say that and how people say that and what it means and what it doesn't mean.
Chapter 1 in the book.
There you go. And for me, it's just it's what I've been, for 32 years, I've been saying it, and it's actually, for me, it's been helpful. And I also am aware of all the other stuff. But anyway, point being that 32 years ago, I was 26, do the math. And I had been trying to stop using substances for about 2 years at that point. The way that looked was I started playing punk rock clubs when I was 16 years old, and that not that that's an instant ticket to addiction, but
Well.
it let's just say that CBGB's in Max's Kansas City in the late 70s as a high school was pretty rad in that way. And so and then I went off. I actually went off to college at the age of 16 and drank my way out of there through the hospital at the age of 18. And I went back to New York, and I was in Philadelphia for college. And in New York, I pursued my music career and pursued as much alcohol and as many drugs as I could find. And, the age of 24, I was in an emergency room with alcoholic gastritis, and a doctor came into the room. This is an important part of my experience is, doctor came in the room and he looked me in the eye, and I could see that he knew exactly what was up, right? It was the first time that somebody just looked at, it's like, I know who you are and what you're doing. And this is why you're here in the ER. And what happened was he came up, and I was with my parents, actually, with my mom, because I had had the attack while I was at their house. And so the doctor looked at me and said, "Do you drink?" And I said, "Yeah, beer now and then." And the doctor was like, "Uh-huh." And so he turned to my mom, hoping that maybe she could shed some light. And he's like, "Does he drink?" And she's like, "Yeah, beer now and then," because I used to keep it pretty hidden from family, except, when I end up in the ER, maybe. Anyway, he said, "Well, I don't understand because his liver's enlarged. I really can't think of any other, sort of explanation." And so that went to the next 2 years of my mom not talking to me, and with me trying to do it on my own, as it were. And then I found 12-step programs through my friend Maggie, may she rest in peace. And she brought me, she's like, all your friends are there. And I went there, and it was a whole bunch of people in black leather jackets who were in bands, and they just weren't on a bar stool anymore, or doing the thing. And so that's how I found my way into recovery. And then my recovery story, the very brief version, the sort of just putting it together, is I didn't work at all for like 9 months. I left the music business. I was part of a record deal when I had about 50 days sober, and I said no. I quit the band, and just really gave myself to recovery, and went for career counseling designed to help people with addictions to find their way. Became a high school English teacher. As a high school English teacher, I was in a neighborhood, Crown Heights, where there was racial unrest. After my first year teaching, the summer after my first year teaching, and found myself in the middle of civil rights work and diversity training and all the rest of it. And I had had a background with that from my grandpa, had taught me all about that. And that led to the next 15 years being about doing diversity training. And then I got a sober record deal with Maggie and some other folks, and lived my life, and sort of noticed the reason I bring this up is because the diversity world is where I really got hyper exposed to trauma.
Yeah.
The trauma of systemic oppression, the trauma of systemic racism, and noticing what it did to people's psyches. And so when I moved out here to LA in 2002 and obeyed the law and became a therapist, a lot of us, when we arrive here who weren't therapists, we become therapists. But I, went to school and immediately became kind of obsessed with the role of trauma, but didn't really have a language or a direction for it. And then in my first associateship or my internship, I was at an addiction center, and the clinical director was using EMDR therapy as a frontline therapy, which was not the norm back then, about 2005, 2006. And I met Andrew Leeds through her. And then I said, "Please train me, because this seems like the thing." And I've been an EMDR therapist ever since. Yeah. And that I've been working pretty much primarily in the addiction space ever since, including, in treatment settings, etc. Yeah. And so I've been able to see firsthand what it is that Jamie and I have now come together. And
Yeah, and in 2012, I wrote the first edition of the book that was Trauma in the 12 Steps. And a couple months after that, I get an email from one Stephen Dansiger saying, I read Trauma in the 12 Steps. I think we're supposed to be friends, that type of thing.
yeah.
And you're coming out to LA. Would you come and speak at this center? And
Mhm.
when Steve and I met, it was one of those instantaneous clicks of like, wow, we're really on the same page
Yep.
about how we approach addiction, how we approach EMDR. And I think a lot of why we really have had this bond, both professionally and personally, is a grounding in 12-step recovery. And as we take on in the book, yes, there's still a lot of controversy and debate around, is it useful in the modern era? Is it trauma informed in the modern era? We also unpack in the new book, is the word addiction even something that's useful in the modern era? Because there is literature to contend that we should be using terminology like person with substance abuse disorder or behavioral compulsivity, that addiction is stigmatizing or outdated. We take the position that the word still has usefulness. Addiction. It comes from Latin meaning addicere, which means to be surrendered to, fixated on, favoring something. And we do use it, it's obviously in the title of our new work, as a good catch-all term, recognizing its imperfections, recognizing, and I think this is a big point that is valuable to EMDR therapists, I don't care what clients call their struggles. To me, a client never has to use the word trauma to do trauma work. They can think of it as wounding or my issues. A client never has to say I'm an addict or the struggle's addiction, but even if they use terminology like, I drink and bad things happen, and I'm willing to at least admit that, it's someplace. So to me, part of being a good trauma focused anything is be flexible in the language you use. And in chapter 1 of the book, we give an extensive primer about all the different things you can call this and all the models that are out there if you don't like the 12-step model. And my position, obviously professionally, and I'll explain why as crafted by my story, is I am a critic of a lot of what happens in 12-step world, as is Steve, especially in meetings in the community where a lot of things are very trauma ill-informed, especially in a lot of treatment centers where there could be this kind of dogmatic institutional, well, this is what the steps said, and this is what the ghost of Bill Wilson tells us to do. Bill Wilson was one of the co-founders of AA. But for me, I had the amazing fortune of being introduced to 12-step recovery by somebody who was a retired clinical social worker. She was trauma informed before the phrase was cool. So my story, hi, I'm Jamie. I'm an alcoholic, addict, trauma survivor in long-term recovery. And one of the reasons I still identify in that way, because that's what mystifies a lot of people outside of AA circles, and we do get into this in the book, is why after 19 years of recovery do you still call yourself an alcoholic? And for me, it is a reminder of what I'm capable of, or where the depths of this thing took me. And when I say it that way now, I don't feel any shame when I say it. To me, it's an admission of surrender, which is very aligned with my spiritual practice. When I say I'm powerless over drugs and alcohol, it doesn't mean I'm a powerless person, but it's an admission that if I put these substances in my body, they very likely will win, because there's ample evidence of that. And at this point, I just choose not to take the risk to do it further, because I've had a pretty cool life in these last 19, 20 years by not doing that. So I'm from Ohio originally. That's where I'm based. And I often say, if you want a good crash course of my childhood, there's an amazing picture of me when I'm 9 months old, sorry. And I'm wearing a Cleveland Browns onesie and a Pittsburgh Steelers hat. So obviously the most bitter football rivalry in that part of the country. And one parent was a fan of one team, the other parent was the parent of another team, and that pretty much typified their marriage and their conflict. And I was exposed to various different types of trauma in childhood. Yet what has affected me most significantly has been this thing that we now call spiritual abuse or spiritual trauma. Both of my parents were rather religious, one very much so. And so obviously growing up, having inclinations that I was queer, I do identify as bisexual from as young as 11 or 12. coming up in an environment where you're told that's an abomination and that's a one-way ticket to hell, will create some stress internally, compounded with other types of wounds I was dealing with. And I actually did not really get into trouble with chemicals until I left my house. I mean, I had dabbled here and there in my teenage years. I would say overachieving and trying to be the best was the way my addictive tendencies most manifested in high school. And then when I got to college and had some freedom and realized, wow, there's a whole big world out there. And a lot of that was good to realize that. But yeah, chemicals soon became very much of an issue for me. And I ended up moving to Bosnia-Herzegovina from 2000 to 2003. My family is of Croatian and Serbian origin, and I followed the war pretty intently when it was happening. I have an undergraduate degree also in English pop culture. That's another one of our connections. And so I primarily worked in Bosnia as a English teacher as part of some aid work that I did. And I went there as an English teacher. I came back as a social worker, thanks to Janet, my first mentor and recovery sponsor. And she basically told me, go back to graduate school. I think you'll be good at this. And I hated psychology as an undergrad. I want to be abundantly clear about that. So when she said, I think you'll be good at this work, I kind of laughed in her face. And the reason she explained why, she said, I see how you are as a teacher, and you have a way, because of your background, to really relate to these kids. That is the core of what helping is about. So now go back and learn the science, learn the technique. And that's what I did. And how EMDR found me was during my graduate internship, I was being triggered significantly. Not by the children I was working with, but by the way I saw the system treat the children, the medical doctors, the hospital, child protective services, criminal justice, all of that. And that's when a lot of my dissociative tendencies that had been with me since childhood really got amplified, because I was no longer using chemicals, which were my avenue of dissociation all of those years. And so I was given a referral to an EMDR therapist, and here we are all these years later. The experience changed my world, changed my life, was so significant because this is a phenomenon, Stephen, I think you relate to, and a lot of people in long-term recovery relate to. I was sober. I still wanted to be sober, but I wanted to die. My mental health was in such a place where something needed to be done. And I felt I had a head full of 12-step knowledge and what the CBT methods would kind of tell me to do, but something was really missing in here and this type of connection. And that's what EMDR therapy gave me. It was my EMDR therapist who also introduced me to mindfulness and yoga, and that has become a big part of my world. And I ended up doing my doctoral dissertation. It was published in 2009, specifically on the use of EMDR in addiction care. I looked extensively at a facility in Columbus, Ohio, that had implemented EMDR, not necessarily, like you said, as a frontline, but definitely as a very strong adjunct, as a part of their overall programming. And they did this in the mid-90s. And I remember meeting their director at an addiction conference in Ohio, which is how I got introduced to the facility. And she just noticed and had data to show how the introduction of EMDR improved their retention at the center, because it was a long-term center. And I just became fascinated with, well, how are they using EMDR? And that's what a lot of my dissertation focused on. And part of the finding of the dissertation goes along with what Dr. Shapiro said in her early writings about EMDR and addiction, that when it comes to treating addiction with EMDR, EMDR should never be used in a vacuum. Meaning, and she qualifies this by saying it should be part of an overall, I don't believe she used the word program for recovery, but an overall system that helps a person in recovery to feel safe and supported. So she said, for example, 12-step meetings being one. And I know at the specific facility that I researched, most of the people found 12-step together with EMDR to be very impactful. But I always remember that something else the facility offered were classes in like basic lifestyle skills. Like one of the women in the study said, I didn't learn how to really boil water till I was 27. Right. And so really attending to people's social and practical needs being part of that. And so while I definitely concur with what a lot of the work Steve is doing, that EMDR can be used as a main treatment modality, and we'll be discussing this a little further, I'm sure. I always like this idea, and this is much of what we'll be going into, that EMDR should never be used in a vacuum. Because as much as I love EMDR, you love EMDR, presumably, a lot of you love EMDR, where I get concerned is when consultees, students, readers come to me and they ask, well, tell me how to do EMDR in addiction. Which protocol do you use? Because as we even talk about in our book, there are 4 or 5 different specialty protocols and twists and turns on the standard that are out there. And what Stephen and I have always contended in our work together is there is not one magic bullet we can give you in, well, this is what you do, and this will quick fix addiction. And when I even think of the irony of that, so much of what the problem of addiction is what?
Well, the problem of addiction is that it is very trauma driven.
Yes.
And that if I'm not utilizing fully my trauma-based, trauma-focused therapy in all of its wonder towards the trauma that leads to addiction, then I'm trying to find some kind of surface or some kind of, like you said, like a shortcut or a quick fix.
And addiction for me is defined by this emphasis on instant gratification, quick fix. And I want to be clear that I say that not from a shaming place, because I 100%. Get that. I've been in that tremendous state of pain due to trauma, due to suffering, where you just want to kill the pain now. So I validate that as a human experience, but does that work in the long run?
Well, and that's something that we as EMDR therapists end up having to work on for ourselves, because we're faced with the suffering of our clients, and there's every desire to jump in there and hug it out or find a way to just finish the job, as it were. But in fact, it's a longer term prospect. And when that's when you're talking about trauma, it's when you're talking about trauma and addiction. It's when you're talking about addiction or other complex presentations.
And Steve and I are very big proponents of the both and dialectics, as it were. And the thing I like about EMDR is I do think it has the potential to come in and give some pretty quick relief.
Yes.
Because of the power of the core methodology of the standard protocol, which Stephen has named Shapiro's special sauce. And we even got away with naming a chapter of the book that. Thank you, Springer Publishing. Thanks. So phases 3 through 6. So EMDR, looking at the one side of the both and, has that potential to bring in some quick relief. But, hopefully this from physical conditions too. Yes, surgery can bring you some quick relief, but there's typically some aftercare involved. Yes. After you have some kind of radical procedure that can give you some quick relief. There may be some prep care involved. And so that's the both of the both and here, that using Shapiro's words, I don't have to use anybody else's really, let not EMDR be used in a vacuum. And part of what we try to do in our work and has really come out in this book is, what are some of the other things you have to take into account? Like maybe the person needs to learn how to boil water, using that finding from my dissertation study. Maybe they need connected, like Steve mentioned, the vocational training that he got. I think that's a very important part of your story. For me, an important part of my recovery journey was needing to explore other different spiritual paths for me to find something that connected well with me. So I go to this idea of, yes, traditional medicine and innovations like EMDR is not bad, but if we harbor and focus only on the quick fix and not look at what St. Hildegard of Bingen called slow medicine, this idea of how do we help people really embrace and change over time. And another thing I was impressed by when I was doing my prep research for the dissertation is how one of the common threads in all recovery programs, even the people who detest AA, comparing what they have in common with AA and 12 steps, is the need for lifestyle change. And so, yes, while the quick relief of EMDR can maybe help a person start to develop a new view of life, in our experience, so many of our folks need practical help learning how to live a new life.
And all of this, or a lot of this, falls under the rubric really of phase 2. It's like everyone's got different resources that they either have. First, we come from a strengths-based perspective, and it's like, what resources does the person have? And then we can both celebrate that and also start to just utilize that. Sometimes folks are able to start helping themselves just through what they didn't even realize that they had. And then we find where, maybe what's either missing or weak, and then we help to find those and develop those and strengthen those. And for some folks, you remind me, you brought me back to when I first moved to LA. Before I became a therapist, I was brought into a treatment center to start running a couple of groups. And I was running anger management and life skills, right? I wasn't a therapist yet, I was a teacher. And so, that life skills group was exactly what it says it is, right? It's just how to live, right? And, even, from a 12-step perspective, right? Years into AA, they came up with that book, Living Sober, right? Which was designed to help people just like do the day to day. In any case, the point being that phase 2 resourcing, the way that we teach it is anything and everything that is healthy and or adaptive for the client that's in front of you.
Yeah.
So, I often give the example of someone, in a very, very, very acute detox from opiates, right? What's the resource that they need at that time? They don't need me to teach them mindfulness skills. They need a bed and some detox meds and, whatever else that helps them to, just land the plane for a few days and a nice meal. Yeah.
Water, lower level Maslow.
Phase 2,
if you will. Yeah, that's all.
This is phase 2.
That's all part of phase 2. So how we're really going to approach this rest of this webinar today is to do a phase by phase unpack. I think that'll be the best way to approach this. But we first want to highlight why we're calling this the standard protocol in the treatment of addiction. Because if you're on any of these Facebook EMDR groups online, you will know that one of the most common questions that's posted is, I have a client who XYZ smokes weeds, this, that, and the other, which protocol should I use? Which protocol should I use? And I'm typically the smart aleck that's like the standard protocol, well conceptualized. And I want to say, I am not impugning the work of people who have worked with specialty protocols. And we're going to name them all right now just to kind of get this out. So obviously the late AJ Popke was kind of the first one who was known for developing a specialty protocol, the detour protocol, desensitizations of trigger and urge.
Desensitization of triggers and urge reduction.
You can tell how often I use it because I don't even know what it stands for. And I'll be honest, one of the reasons I have found it to be a good entryway in some of my work with people who are overwhelmed by the idea of looking at the deep dark portals of their trauma, but realize that craving and urge is an issue. So I have used Detour as a setup occasionally, but honestly, my friends, I have never personally, Steve may have some different experiences. I have never used Detour when it hasn't opened up the need for standard protocol. And Popke acknowledges that it might open up the need for standard protocol. And so that's the biggest way I have ever used Detour. I do like his idea of positive treatment goal as well. You've probably used it a little bit more.
Well, yeah. So when I got trained in EMDR therapy, AJ lived about 20 minutes away from the treatment center I was working at.
Right.
And so after I got trained in standard protocol, I got to spend a significant amount of time with him and learn Detour and kind of learn what it was about and how it could be used. And then especially back then, 2005, 2006, not a lot of people were talking about what we're talking about, which is using the standard protocol as a frontline therapy or one of the frontline therapies for treating addiction. And so the way that I've used it over time, like this has evolved, is now it's one of my tools that I have where when I'm working with a client long-term and they come up against their urges and their cravings again, they come in and they're like, you know what, I can't really talk about anything today other than the fact that I'm fiending and I want to get high. It's like, oh, would you like some EMDR therapy for that? That's pointed at that, right? And so that's one of the ways, that's the way that I use it. And that's one of the ways that can be used. That's a different conceptualization of how it originally came about. And then also keeping in mind that in the protocol as it's written, Detour, and if stuff comes up, go to standard, right? And that's true of many specialty protocols.
And let me tell you, my friends, if nobody's told you this yet, I feel like we need to have the more you know logo. Remember from
Yeah.
NBC, right? Any of these specialty protocols are just twists and turns and variations of the standard protocol. And so I have always felt if you learn the standard protocol well, you can learn one of these variations simply by reading or watching a video. Taking a training might be useful to you if you find them useful, but this is where, even though a lot of you know me as a rebel in EMDR circles, I really am kind of vanilla in terms of learn the standard protocol well, and you'll have a lot of what you need. So more on that. Detour is the first and definitely the most popular. And then we had Kravex, which came out of the work of Michael Haas and his team in Germany. And similar, yet I find Kravex, and this is the one I would probably have the most likeliness to use. It's very aligned with standard protocol, but uses this language of level of urge instead of SUDS. His protocols are written up in Marilyn Luber's books. He's had some peer-reviewed literature that kind of gave the base for Kravex. And we also have Springer in our new book gives you access to all these specialty protocols. And we talk a little bit about how to use them, but if you want to read kind of the backstory on each of them, you can definitely. So Steve, kind of looking at that spirit of Kravex, have you ever used more of the standard protocol to target a craving?
Oh, so to your point, and sort of what brings us sitting here together is because of the direction that my EMDR work took, a number of years ago, and particularly thinking about my the words that I use constantly in consultation and supervision and working at treatment centers is it's always EMDR, right? That EMDR therapy is a complete psychotherapy, and so language-wise, anything that is part of the case conceptualization for addiction, generally I can find where it sits in the 8-phase protocol. I can see where it sits in the AIP model, and so that includes urges. And one thing that is alternative, as it were, that I use is from you, which is the list of addiction-specific beliefs. Right, that's where I find more. I find more access to what it is that we're talking about. Where a belief like I cannot live without alcohol, or I cannot envision a sober life, or whatever the belief is. So I just want to also put out there that one of the things that makes me very happy, and this comes from a lot of working with you over these years, is just having a deep respect for all the work that's going on throughout the EMDR community to try and help people to understand what we're really addressing in this book, which is that we can address addiction with EMDR therapy. Our belief is we can address it with the standard protocol primarily. And when I look at, like, for instance, Kravex, they're in the midst of multiple RCT studies at treatment centers throughout Europe. The folks who did the palliative EMDR interventions in addiction,
which we'll talk about later.
Absolutely. That started with, sort of a research-based theory, and then sort of a collection of the literature literature review in order to find what it is the best practices are with addiction. And now they're, sort of putting it into action, right? So that's the goal, right? The goal is how can we all of us who are trying to treat addiction with EMDR therapy increase I was about to say velocity, but that's not the word I want. Yeah, I know, right? Yeah, as if EMDR isn't fast enough, to just increase the power, focus, power and the focus.
Yep. So the other specialty protocol that I'm probably gonna have Steve talk more about this, because you could probably tell I have some feelings in that. I will say I saw EMDR therapists go the most cuckoo for Cocoa Puffs over this protocol, because I think it offered the greatest chance of more of a quicker fix. And this was the feeling state addiction protocol based on the work of Robert Miller, which I'm going to have you take it, because I'm going to sound biased on this. So go ahead.
So here's one of the ways that I can frame this and frame all the rest of it is, everyone who has come up with an alternative protocol for addiction has had this idea, I want to heal addiction, right? And what I think has mostly happened is that we've discovered, and the palette of EMDR interventions in addiction addresses this. I feel like what we found is all the best practices that work within the standard protocol that are parts of what it is that we're addressing. For instance, feeling state protocol is addressing that feeling state that I know that you know about, and that I know about, that first time when I was 12 years old and I had a lot of things I needed to heal. And I was introduced to alcohol and weed, and I tried it, and it healed everything automatically, right?
Mm-hmm.
It was just like, bam, I now understand how to live. And what happened was, unfortunately, right away, I got consequences. I grayed out, I blacked out, I threw up, I did all those things.
Mm-hmm.
But the next morning, when I woke up with the hangover that was worse than any migraine I had ever had, and I was a migraine sufferer as a kid, I ended up thinking, oh, well, do you have any more of that stuff? And what time are we starting tonight?
Mm-hmm.
And that began the process. And feeling state is generally there to disconnect, or to do a reprocessing
Mm-hmm.
of that positive connection
Mm-hmm.
between the substance and the beliefs and the behaviors and the rest of it.
Mm-hmm.
So great. That's one for me. That's
Mm-hmm.
one of the targets. That's
Mm-hmm.
one of the parts of the treatment plan. That's one of the things I need to address. And sometimes I can address that just through standard protocol. And perhaps if I find it helpful, then I can work that way with feeling state. But I guess, yeah, where you and I agree, it's sort of seeing any one of these protocols as the protocol for addiction.
Mm-hmm.
For us, with everything that EMDR therapy, the standard protocol, has to offer in a comprehensive fashion, is short-sighted.
Yeah. Yeah. Uh, yeah, I think feeling state's a great idea for sure. And I think if done, again, properly conceptualized, if it makes sense for the person doing it, how they're doing it in their treatment, because there's something that April Wise and I uncovered in our paper from 2016, and it was actually based on her dissertation research, which is that, and I just want to comment here for those of you who are joining us live, I am getting some comments about the video stream being choppy, and I could see on our end why it is here on Facebook. I will definitely be posting where you can watch the replay later on YouTube, which will be a cleaner link for the next week or so. We'll have that up. So I apologize. There's not a lot I can do right here, right now about some of the streaming stuff. I think part of it's internet, part of it's Facebook, part of it's having some funky messages popping up that I'm not really sure what they mean. So please stick with us. And I know some of you are doing fine with it. Some people are. So we'll take it as it goes. Okay, so feeling state. Also, if you do choose to get the new book, I will say Adam O'Brien, who's one of our colleagues, I've done a lot of work with him, writes what is essentially to me a little bit more of a reverse protocol, where you're using the standard protocol, but it has more of you're kind of swapping the positive cognition and the negative cognition when you're talking about some of these feeling states and addiction memories. And then a lot of people consider the work of Jim Knipe to be kind of his work from rewiring the affective circuits, which a lot of people know to be part of what can be used to help with addiction. Have you done much with that or no?
Not as much, no.
Yeah, but it is covered in the book as one of the practicals that you can use. And again, Springer has information on where you can get to the full thing. For those of you who may be having troubles with the stream, we're getting a note here. I switched from my computer to my iPhone, and for some reason iPhone is better with minor choppiness. So thank you for that note. Okay, let's one other thing I wanted to mention is, and I think this is not just a addiction thing, but it certainly is something that I think is more of an EMDR kind of cultural problem, which is this tendency to everybody always wants to come up with their own specialty protocol. And even now, like we're getting, like Laurel Parnell has the, connecting the consequences of addiction. And I read that people are kind of coming up with new protocols. And I just want to say what I said earlier, that all protocols are really just variations on the standard. And we are going to talk to you here in a minute about how to conceptualize standard protocol, perhaps using the greatest hits list of addiction specific beliefs, which is what we talked about. So what I'm going to propose we do here before we get into really unpacking this phase by phase, if you're here in real time and you've crafted the time, stand by. I'm going to stop the stream and restart it again. So at this point, while we're waiting for people to come back, are there any questions or comments that you might have at this point? Anything resonating with you, anything landing with you that you might want to comment about? And our plan here for the second part of the workshop is to go into a real kind of phase by phase breakdown, having established that for Steve and I, the standard protocol is really much of what we use. As I say, when I respond in a lot of these groups, the standard protocol well conceptualized. And part of that good conceptualization is what I said, knowing about the whole picture around addiction, the various ways it can be defined, the various ways it can be approached with people, looking at the importance of lifestyle change, attending to social needs that people might need met, etc., etc.
Yes.
Etc.
Yeah, which is all doable, right? Which is, especially if you're looking at phase 1 and phase 2 through that lens that you just described, then you're basically honoring the fact that every client that comes before us has a different history, has a different set of resources, has a different set of difficulties or diagnoses that, besides the addiction, and the addiction can manifest in so many different ways. And so, yes, the standard protocol, well conceptualized, phase 1 and 2, really, sort of almost like a little bit of segue into unpacking all 8 phases, but allowing ourselves to see a client from the very beginning as being in this process of EMDR therapy.
Very good. So we'll give people another minute or two to rejoin us. And again, if you have any questions, comments, anything that's resonating with you, please go ahead and put it in comments. Okay. So why don't we get ourselves recentered again? I'll have you maybe start it, and then I'll finish it off with a little bit of moving mindfulness.
Okay.
So go for it.
Well, going to perhaps take what we did earlier and just take it one last step. And so just for a couple of minutes as opposed to 5 minutes. And so just let's go ahead again, eyes open or closed, whatever the posture is that feels like the right posture for right now. And once again, checking in on the contact points. And you can include the breath as one of your potential contact points. Just, the back, if it's against the surface, the seat, the backs of the legs, whatever is making contact with the surface. Just really scanning them, not quickly, but rather, just There's that one. There's that one. And including, if you like, the contact points of the breath. And if any one or more of them feels like a spot that you can land on just for, I don't know, 30 seconds, go ahead and just take 30 seconds with whatever that level of ground or just noticing is. And even in a brief time like this, by now, a thought or two or more may have come through your consciousness.
Like, I'm the biggest failure because I couldn't get the tech to work for a live webinar.
I can take that one on.
Go on, my dear.
I didn't provide sufficient internet.
I think it's Facebook, but
Okay.
okay, we could battle that.
Anyway,
okay.
But
live in the full catastrophe.
Noticing that you have had that thought or two or more, and knowing that that's completely normal. And so in this practice, just noticing that, and then coming back to whatever your object of meditation is. And we may have to do that many times, even during a short sitting like this. It's also normal, so don't worry about it if you can. And whether it's once or twice or many times, same practice, same success rate, just coming back to awareness over and again. And we'll sit in this way for as long as you would like to, Jamie, because Jamie will then take us into a more movement-based practice.
Let's take about a minute.
Okay.
And then on your next inhale, really notice the expansion of the center body. And on the exhale, pucker your mouth slightly as if you're about to exhale through a straw. And slowly release that air. Let's try that 3 to 4 more times at your own pace. And what are you noticing now? And from this place of what are you noticing now, I'd like you to use your body to help you respond to that. So you might notice I just took a big wake up stretch, maybe some twists, some turns, standing up if you've been sitting down. This is really the essence of going with that, noticing that. And then if your eyes have been closed, let them gently blink open. Reattune, readjust to the light in your space. And this is something I mentioned throughout my work, that one of the great risks to promoting a bigger sense of dissociation or drift is if you have a person to have their eyes closed for so long and then they've been locked shut and then woof, like they suddenly open. That disorientation can be part of what causes some overwhelm. So whenever you have eyes closed, please, please, please take your time being subtle with, okay, let the eyes gently blink open and take that time to readjust. Something I often emphasize in mindfulness teaching is transition is part of the mindfulness practice, which is why I get concerned when I see EMDR therapists rush too much through phases 7 and 8, that those phases really are there for transition. So we have one question that I truly want to address, because I do think it's an amazing bridge between what we did in the first half and what we want to do here in the second half. So as I've said several times, my answer is typically, which protocol to use for addiction, the standard protocol, well conceptualized. So Steve, when you hear well conceptualized, what does that bring up for you? Because EMDR emphasizes the importance of case conceptualization.
Yeah, so what it brings up for me is that something that Dr. Leeds said to me in my initial training was case conceptualization is all. That if you conceptualize the case solidly through the AIP lens and through the 8-phase protocol lens, and use all the rest of your clinical acumen and clinical knowledge in order to inform that, then you will find the right direction for the treatment of the addiction and anything else that's going on with that client. And what that also entails then is that it allows you to see the addiction not as this separate thing, right? And that's often that's a problem, I think, in the clinical world in general, right? It's like they have they have PTSD, and they also have addiction. We have to treat the addiction first before we treat the PTSD, or vice versa, or so it's no longer about separation. It's more about, addiction has so much, in common. I'm not just talking about comorbidity, but, so much in common with anything and everything else that folks come into us with. And it all goes back to the trauma. So that's what it brings up for me, is that I'm conceptualizing the addiction through a trauma-focused lens. And that changes everything in terms of how I might use the standard protocol.
Yeah. So case conceptualization is a word I first learned when I took EMDR training. And honestly, the first kind of cycle of my training, I'm like, what is this case conceptualization of which they speak? Maybe I wasn't listening, or it wasn't very well explained to me in my particular training. Yet, as I started working and reading EMDR text, it became clear, case conceptualization is treatment planning with respect to the AIP model.
Yep.
Because in addiction services, we have to do treatment plans. Yes. Which I think often bring up dread for a lot of clinicians, because it's this very technical formed thing you have to do. But something that I really look at is to embrace this idea of treatment planning, having a person establish what their goals and intentions are for services, because I think that's one of the first important things about getting on the same page. You may want abstinence for this person. And especially as 12-steppers, that's something we often have to kind of confront in our own biases, right? That we're abstinent, so we would hope everybody's addiction path would involve that, but that's just not the case. And that's one of the real contributions, for instance, of the Detour protocol, is it is very much at its heart a harm reduction model. And so for some people, that may be more of their goal. So that's really the first part of treatment planning, is to make sure that you're establishing what the person's goals are for even coming into services, and then looking at how you'll unfold with interventions. So the AIP model, if you're an EMDR therapist, this ought to be familiar to you, is the adaptive information processing model. And you could read this in your EMDR texts if you need a refresher on it. Yet the essence of the AIP model is that one way or another, it all comes back to trauma. whether it's the cause of the pathology or the presenting issue, or whether it's an exacerbating factor, the presence of unhealed, unprocessed trauma, which often reflects in various symptoms, typically reflects in a negative cognition or 2 or 10, can be what amplifies why they're coming to see us. So as we do this phase by phase breakdown with standard protocol, we are going to start with client history, because this is really the groundwork for where you get the case conceptualization, to know where you're going to be steering the ship with the EMDR therapy. So Steve, you have a great amount of experience both in private practice and in working in addiction treatment centers. That's part of what you're known for here, is really bringing EMDR therapy into addiction treatment centers. Can you explain a little bit your approach to client history?
So one of the common language, I'll call it a problem or a situation in the EMDR community. And again, this is not me wagging a finger, this is just an observation, has been that the language of whether or not we're going to use EMDR therapy is about is this person able to do EMDR therapy? When the real thing that they're asking is, can this person do reprocessing right now? Because a lot of people have this conception of phases 3 through 6 being, it's a 4-phase protocol, right? Like this is EMDR, and nothing else is EMDR therapy. So the approach to client history is, instead of using that language of, is this person appropriate for EMDR therapy? Again, this is my approach, is everyone's appropriate for EMDR therapy. And that when a person arrives, from the from the admissions call to, intervention to intake, all of that is part of phase 1 and phase 2.
Right.
And in speaking of phase 1, it's linear and it's not linear. A lot of the protocol is fairly linear. But 1 and 2 are very, they can flip-flop, they're very intermingled. So thinking about client history, when someone comes into a center, for instance, it's like they are, from the very first intake, all the early intake procedures are part of phase 1 of EMDR therapy. And the result of that is that I am now immediately conceptualizing the case from a trauma-focused perspective. And so that's the overarching sort of premise of the way that I approach phase 1. It's our taking the trauma-focused approach and leading with that and having that be our guide.
There are a lot of different methods in the EMDR world for how to take client history.
Yes.
And we emphasize this in a lot of our writing. And depending on who trained you, you probably learn different ways to take client history. I know, having a pretty traditional EMDR training, I learned the good old 10 worst memories, 10 best memories technique, which, can have some utility. I never really found that useful, because a lot of the more complicated clients I worked with, they got activated even listing some of their 10 best, let alone some of their 10 worst. So I have found that to be not what I tend to use a lot. Especially in the 3rd edition of her book from 2018, Shapiro discusses potentially using the ACEs inventory as a way to take client history. And any of these inventories that you might use in your clinical delivery could be used as a source of client history. And client history, there's a lot of moving pieces. As part of client history is doing your clinical intake as you might normally do it. But the more you learn about trauma, I feel the more awareness you have to seeing what you're seeing. So it's asking about medical difficulties that a person has encountered to see if that might be a complicated factor. In the case of addiction, you have to assess for a detox necessity, really, as part of your client history. And if there are any outstanding medical concerns that need addressed, living situation, lifestyle issues, not using lifestyle as a pejorative, but just where are you living? Are you getting food? Some of those, like we mentioned, lower level Maslow needs. So a lot of client history is doing intake as you normally would, getting a view of the picture. In a traditional EMDR sense, part of client history is also beginning to look at essentially farm out targets. Like, what are some targets we could then later use in phases 3 through 6, but what are the roots of these negative beliefs, negative cognitions that are driving a person's maladaptive behavior that's bringing them in? So, giving you an example, and I'm not saying this will work with every client, but I mentioned using inventories you might already give as a source of taking client history. So take the DES, for instance, the Dissociative Experiences Scale, which most EMDR training programs advise you give to people, especially who have a complex trauma history, just to see where things are standing with dissociation. So this is a whole other training I could do and have done that. Clearly, dissociation inventories are imperfect. What I like about the DES is it's not that long. It is meant to be more of a screen than a diagnostic, and it's a great conversation starter. And you can have some of those conversations in the lens and the understanding of AIP to ask, where do these things come from? Where did they start? So like one of the items on the DES is you're driving and all of a sudden you don't remember getting in the car or realizing how far you've driven. So if a person says that that happens to them quite a lot, like over 30 to 40% of the time, I might use that as the conversation starter to ask, thinking back over the course of your whole life, hint, hint, which is what we often use to get at targets, can you recall when this behavior began? Mm-hmm. Was there anything else going on in your life at that time? Mm-hmm. And that often gets you to a source of some history, which can be potential targets. Do you have an interjection there?
No, just, in the early intake process, combining that with a very, and I know that you're, advocate for this, a very strong attempt to create rapport. Mm-hmm. which is a delicate balance,
and it's part of phase 1. To be clear,
which is part, it's part of phase 1
dynamics for sure.
EMDR therapy is a very relational therapy, even when we're just waving our finger. Yeah. Mm-hmm. So just adding that in as much as how do we get, we don't need chronology, we don't even need all the information up front. We just maybe need some newspaper headlines. So since we only need newspaper headlines, why not spend as much time as we can just building the relationship? Mm-hmm. Building the human trust factor, mm-hmm. While being discerning about which tools, when, which scales, which interviews, some of which, like you pointed out, to your point about in addiction services, often like in treatment centers, or, that there's certain things that we have to do, mm-hmm. Depending on the licensure of the center, et cetera. Mm-hmm. But, so finding trauma-informed ways to deliver those, and also finding ways to make them into our client history, mm-hmm. EMDR client history friends.
Right. So Steve brought out a big point in how we teach this, that chronology is typically impractical when you are dealing with complex trauma. Doing a whole narrative history from the ages of 0 to now, I mean, even though some people can do it, a lot of times they can get overactivated by doing it. And for many clients, it's just not possible, because one of the impacts of unhealed trauma on the limbic brain is not being able to keep a story straight. So we tend to advocate, and we discuss this in many facets of our work, for what is more of a thematic history. And this to me is part of proper conceptualization. And a lot of people get confused, even who we train, about what is thematic history. And I'd like to explain that taking history from a thematic perspective is something that is very phenomenological. And one of the examples that I like to use of explaining the difference between, let's say, linear history, chronological history, and more of a thematic history is to look at one of the sacred teachings of our field, not even EMDR, but just the field in general. And that's Elizabeth Kubler-Ross's Stages of Grief, which originated as Stages of Death and Dying. So a lot of you have learned that the stages are grief, bargaining, anger, depression, and acceptance. And, one stage happens, then the next, and you move through the stages. And Kubler-Ross herself even said these were not meant to be some linear stops on the timeline of grief, that it is very possible for you to feel all 5 experiences all at once. It was not meant to be linear. I will argue it's our field's obsession with having things in linear and 5 easy steps that turned it into a stage model. Kubler-Ross, like myself, was a phenomenologist, and when she conducted this original research, it was to find the themes. What are the themes that are at play with people who are dying? And then, in later work with people who are grieving. And the 5 stages were really themes: denial, anger, bargaining, depression, and acceptance. So let's take one of those, like denial. And you mentioned your family, like, wait, we don't have a drinking problem. He has a few beers now and then. And for a lot of people, just keeping to the theme of the workshop today being with addiction, let's say a person's presenting issue is, oh, people say I have a drinking problem, but I don't really know if I do. So even though they may not be on board with labeling that denial, you might kind of get at them, well, what does this really seem to be about? And that's the way that you can get at theme, and so denial might be a theme. And then you go to a standard negative cognitions list, which you can get in a Shapiro text or whoever may have trained you, and have a person really ascertain what are several of the negative cognitions on that list that seem connected to your current state here, let's say of denial. Or for some people, their primary driving theme may be depression. Like, I'm just so depressed all the time because I'm drinking so much. Give them a negative cognitions list really as a bit of an inventory. So Stephen mentioned earlier something that I've used in my work for over 10 years, which is what I call the greatest hits list of addiction-specific beliefs. You can get it in really any EMDR book I've done. If you've trained with me, we have it in there. And I believe it's even on the ICM site under addiction and dissociation resources. And basically what I've done, this is the closest I've come to putting a specialty protocol out there. And as you'll notice, it's not even a specialty protocol, because it's just, you use the standard protocol, but you use a negative cognitions list that is more addiction focused. So some of the negative beliefs I have on there is, I cannot cope with my feelings without alcohol, drugs, etc. My addiction is my identity, which is a negative belief a lot of people carry. I struggle, I cannot see reality. So you can check out the list. And again, it's on the Institute for Creative Mindfulness website under resources, addiction and dissociation resources. And again, it's in anything that I've written. So to me, that has always been a way you can use standard to conceptualize in phase 1. And also a point I hit in a lot of my work is you can use recovery roadblocks, hindrances. So for some people, particularly if they're working a 12-step model or 12-step program, they may have a hindrance or a block around, let's say, working the 4th step. And I have quite a well-known demo on that you can look at on my YouTube channel about using the standard protocol to set up a block around working a 4th step. So that block, which may be, I can't look at myself, that's the theme. And then from there, we ascertained a couple negative cognitions, did a modification on a float back to get at, well, what's the first, worst, most recent that these came up, or you can do more of a conventional float back technique on it. And that's how you can do a setup. But even that part of client history, setting up the targets, getting the information that you need for targets, really has to be done with respect to the person's whole life state right now. And they may need the detox bed. They may need connected with social services. They may need to focus more just on rapport first before you get into all this EMDR finesse. So Stephen, at the treatment centers, because you've now introduced and have cultivated EMDR at several treatment centers, how would you recommend, how is phase 1 used in concert with what we might call the intake at a treatment center?
So what we do when I'm working with a treatment center, and essentially when I'm working with a treatment center, we are making mindfulness and EMDR therapy the central therapeutic devices that everything else kind of folds into. If you think of like a 12-step center.
Fold in the cheese, you Schitt's Creek fans just had to put that in, fold it in. Folded in. Go
Folded
on.
in. I thought it was going to be like when you said folded the cheese. I thought it was a Gordon Ramsay. Anyway,
Go on.
I haven't done the Schitt's Creek thing yet. I know. I'm very behind on TV. Anyway, when you go to any center, it's a 12-step center or it's a smart recovery center or any of these kind of centers, it's not like they're only using that. They're bringing other pieces in. They're adjunctive, or maybe they're ancillary, or maybe they're folded in nicely like cheese. Where with EMDR therapy, what we've come to discover over time is that it's a very integrative therapy. And as a matter of fact, there's an entire book from 2002 that Francine Shapiro edited with people contributing from throughout the psychological world in how integrative it is. And so working with a treatment center will say, hey, the center lane, or the way that we're framing this, is through the 8-phase protocol. So then what that means is, as I was saying earlier, person comes into the center and they're in phase 1. Mm-hmm. So anything and everything that center chooses to use as intake procedures, everything about the milieu, everything about the way the groups are structured, everything is designed to either support or provide the 8 phases of EMDR therapy. So thinking of that from the client history perspective, when we're a treatment team, we're all kind of helping out with, discovering the history. Mm-hmm. We're having clinical meetings where we're talking about that clinical history, and someone over here, one of the case managers heard something that we didn't hear in our therapy sessions. And so we're gathering this information. It's actually, it's a wonderful place to do EMDR therapy, because you have like this team kind of working on all these different aspects of the mm-hmm. of the case. And then when we're talking about it in our case meetings, it sounds a little bit more like an EMDR case consultation than it does standard treatment meeting. And so what's happening is we're looking at all of this intake, all of this history, and all of the rapport building that's going on throughout the milieu mm-hmm. as part of phase 1. That's how phase 1 is done.
So, very well. That's how phase 1 is done.
That's how phase 1 is done. It runs.
So if you've been in the EMDR world for a while, you know that there's often a lot of dance between phase 1 and phase 2. Because of course, phase 2 is preparation, which we generally define as anything that you may need to do to help a person be able to handle what might come up, not just in phases 3 through 6, but in life and recovery. Mm-hmm. And I think we've all had it happen where we've done some phase 1 client history with the person and they've got a little overwhelmed by it. So then you may have to pull from your phase 2 skill set to help them, or you may actually need to do phase 2 first or together with phase 1 before you get into more of the targeting part of phase mm-hmm. 1 or identifying or selecting the targets. So we just want that to be understood, that phase 1 and phase 2, sometimes I think of them as one big phase in a lot of
and in the work that we're doing at treatment centers, very much so. Mm-hmm. It's just I just call phase 1 and phase 2 a mosh pit. It's they're all happening all the time, mm-hmm. right? For instance, the milieu, just the fact that people are amongst other people in the treatment center, mm-hmm. that's a resource. Yeah, like they're getting phase 2 nonstop.
Yeah.
And same with, just each group, each mm-hmm. interaction, like that.
So that being established, let's go more into our approach to phase 2, which we've kind of touched on already, being so mindfulness focused. Yes. But I find, first of all, I just want to say I am so glad that Dr. Shapiro named phase 2 preparation instead of stabilization, mm-hmm. as it's often called in just trauma therapy in general, because I feel sometimes EMDR therapists and their clients could set themselves up to fail thinking, well, the client's not stabilized enough yet. And I really just even like that language shift to, is the client prepared enough? Are they prepared sufficiently to go further with the work? So I really, really, really like her use of the word preparation, something Stephen and I have both emphasized through much of our work, and hopefully this is not new to you listening today, is that preparation must involve, this is another the more you know, preparation must involve more than just one calm, safe place exercise. Because once more, in the early days of EMDR, back when people walked uphill to school both ways in the snow, that was kind of it. That's what Shapiro taught as part of the training, was make sure a person has a safe place. And there's obviously a plethora of potential problems with that we know now, who work with complex trauma, that for some people the word safety is just such a loaded word. There might not be such a thing as a safe place, and you might be able to switch around to calm or happy, and you might have some variations. Safe place is fundamentally a dissociative exercise, because even though it could be adaptive dissociation, you're asking a person to leave their present experience. So with a lot of my most dissociative clients, I don't even use a safe place. It's more about how do we do grounding to make sure you're okay in the here and now and with what comes up. Other potential problems, not everybody's optimally visual. So in our particular approach to EMDR and training, we emphasize what is a comprehensive approach to preparation. And we know that one of the great debates in the EMDR community is some people seem to stay too long in preparation. Some schools and camps of EMDR just kind of breeze through it, thinking, well, you're not actually going to get to the heart of what's wrong unless you do trauma work. But that can obviously come with its share of problems too, if a person can't handle what's going to come up. So we try to take as prudent of a approach as possible, which is, yes, you have the navigation between when to move from phase 2 into phase 3 has to happen on a case-by-case basis, and we'll cover that here in a bit. But you really set yourself up for a greater chance of success if your phase 2 repertoire is extensive. I like to share that even though I've been doing EMDR for 15 years and teaching it for a lot of that time and researching it, I'm a yoga teacher, meditation teacher, Steve's meditation teacher. We're both still always on the lookout for new phase 2 things we can do. It's like there's never enough you can have in your repertoire for ways to ground, for ways to help people bring in these resources. And resources, I want to be clear, because I know I'm already getting some comments here. A lot of you associate EMDR resourcing as, well, resource figures, which it could be. But from an addiction perspective and from a general trauma perspective, resourcing is really just anything and everything a person can bring in to the service of their recovery. So can you speak a little more to that as I cough here?
Yeah, I
Take over, Stevie.
I can speak to it first, going from that resource figures, much like what we were talking about earlier about the specialty protocols being parts of addiction. Resource figures are one of the resources that people might have. And then go back to what you were talking about with, calm place and people not being able to visualize. One of the things that I find, I'm going to say, tragic, when this happens, and it happened more often, I think, in the past, where I would hear people say, we couldn't do EMDR therapy because we couldn't get a calm place. Yeah. I mean, and so there it is. Someone didn't get treatment because of that idea. Now, so here, to me, this is, and I say this to my trainees, this is one of the benefits of being trained in 2021 is, we've it's 30 years later. We know a lot more about, what is potential there, what is there for us as resourcing. And Shapiro gave us all a gift, with Complace and Lightstream and Container, and the acknowledgement that in order to move forward with, and here's another language thing, and you stated it before, in order to move forward with reprocessing, right? Because a lot of times the language is to do trauma work.
Or to do EMDR.
Or do EMDR. All 8 phases are EMDR. All 8 phases are trauma work, right? There's 3, if you look at Genet, there's 3 stages. There's, and of course those stages move around and they're not stages. But whole point being that we now have this wonderful wide world of resourcing that we can do by just being completely open-handed and open-minded and willing to consider that resources are anything and everything that is helpful to that client in front of me. And then looking at it also from, we're talking about preparation rather than stabilization. Let's flip to the word stabilization. Not everyone needs to be stabilized as much as, another person, right?
Mm-hmm.
Someone comes into a treatment center, an example I use, and I think it's in the book, where you have a person who uh, was on a 2-week run with opiates after like a 2-year sobriety period, and before that they've had sobriety on, and they have all kinds of, they have a mindfulness practice, or they just have resources, right?
Mm-hmm.
Then someone else comes in at the same time that off of a 10-year run with opiates, they've lost everything, and everything is, they're physically compromised. Those are two very different cases that oftentimes people will see the same.
Mm-hmm.
They are here just off of opiates.
Mm-hmm.
And so when I'm doing a trauma focused case conceptualization and I take the history, that person, and this is not this or that, black or white, but that person who came in, with those resources in that 2-week, run, may be resourced enough to be going into reprocessing phase like almost immediately,
Mm-hmm.
which there's a case in the book that's like that.
Mm-hmm.
And then that other person, they may also in a 30, 60, 90-day stay. We don't know. We have to make those assessments. So a lot of this whole sort of resource argument that goes on, actually, to go kind of Buddhist on it, right? There's the people who want to breeze through it. There's the people who want to stay there forever, and we're seeking the middle path,
Mm-hmm.
right? The middle path being, how do we get that individual prepared to do reprocessing, to be able to tolerate in between sessions and
Mm-hmm.
tolerate the progression of the treatment.
So taking this forward in the book, but really this permeates our work. And this is based on some of the literature of Garland and Howard and the meta-analyses they have done about the use of mindfulness in addiction treatment. Take EMDR out of it for a minute, but just mindfulness in addiction treatment. And we see from their work that there are 4 primary sets of skills that need to be taught to individuals that can engender positive recovery outcomes. And those are, of course, mindful breathing, of which we did a little bit today. And to the point that we made earlier in the webinar, with respect to some of the trauma-informed instructional methods, not forcing deep breathing on a person, which is why I like their emphasis on mindful breathing instead of deep breathing. And we can't get into breaking down all of the instruction in a webinar of this size. But if you go on my traumamadesimple.com site, if you get any of our literature that we've put out there, we have a lot more instructions specifically on how to use mindful breathing. So mindful breathing is one of the skills that's imperative to do in phase 2, we feel, based on this literature. Body scanning, of which Steve did during our opening meditation in the webinar, a nice modified one. You can, of course, do more extensive ones that we also have in the videos and in our literature. Mindfulness of craving, which is being able to teach an individual how to notice, to be mindful of the first signs of craving in their body. And there's a skill we both teach that's a good precursor to that, which is the mindfulness of feeling tone exercise, being able to notice experiences, sensations as pleasant, unpleasant, neutral, and even getting a person to the place where they can describe their craving and then notice what they need to do in response. And this, I would argue, is where, and we're going to talk about 2.5 here next, which is a term we've coined, where I think as part of preparation, bridging into phases 3 through 6, this is where something like Detour could be useful. And then Garland and Howard also talk about informal mindfulness, which can be this idea of mindful movement, taking a walk, the idea that any human activity can be turned into a vehicle for practicing mindfulness. So if a client does the whole, I don't do this mindfulness thing, I don't do this meditation thing, you might say, well, what's one thing you do in your life every day? Full stop. And it could be something as simple as brushing the teeth, taking a shower, which may be new and radical for people in recovery, trust me. So maybe working with them on how to turn that daily shower into a mindfulness experience. So that's part of it. So once again, it's mindful breathing, body scanning, mindfulness of craving, and informal mindfulness. To the point of mindfulness of craving, especially because you have the treatment center experience here, how do you work with people on working with mindfulness of craving and awareness of craving?
So there's a number of ways, and you already touched on one of them. Actually, lean significantly into the mindfulness of feeling tone, which is a practice, not just derived, but sort of derived from the historical Buddha, who taught about the four foundations of mindfulness. And so one of the ways that we help develop a sort of a full kit of mindfulness tools to deal with both craving and the rest of the aspects of the experience of life, which are becoming alive as the person lets go of the substance, is mindfulness of body. So when you're talking about the mindfulness of breath, we're also talking about the body scan. We're also talking about just anything to do with the body. The mindfulness of feeling tone is actually the second foundation of mindfulness, according to this teaching. And so being able to sit and have it be pleasant, unpleasant, or neutral, rather than pleasant, unpleasant, maybe neutral, right? So we're finding a way to help people to get out of those extremes. I mean, addiction is a problem of extremes. And so how do we help people to be able to notice the craving and the unpleasantness of it, but be able to just label it as unpleasant, right? And be able to do that over and over again with support. One of the things that one of my earliest mindfulness teachers taught me was that this practice of mindfulness is not actually a practice of the mind, it's a practice of the body. And not only that, he also said that this practice is a group practice, right? And so again, treatment center image, when you have a treatment center, you have a group, you're able to do a group practice, and the energy of a whole group of people sitting and not using a substance all at the same time, while sitting quietly and observing, that distress or lack of distress, right? As folks are feeling better. That's a major way that we work with folks on the craving side. And then the other two foundations of mindfulness, one is mindfulness of mind. And in a sense of all the four practices, that's kind of, I call that the most advanced, because that's really being able to track the mind without being taken away by the mind. So without saying that I'm skipping it, let's skip it for a moment and go to the last practice, which is mindfulness of Dharmas, which translation is, mindfulness of teachings, mindfulness of spiritual and psychological and teachings and conceptual thought. So that's where helping people with craving, we give them the opportunity to consider like small and large teachings and use that as, call it a very strong positive distraction that also has its own benefits, like meditating on loving kindness, meditating on compassion, meditating on self-compassion, meditating on just the truths of life that they understand at that juncture of their treatment.
Yep. And so kind of the bridge here, and just to address a quick question we're getting, the reason you want to have the toolbox of different skills for phase 2 is certain people are going to respond better to some than to others. And I think the most successful EMDR therapists are the ones who don't go in with a rigid, well, we got to resource this. Okay, you can give them a try, but to be open to that flexibility that people will respond differently.
And thinking about too the different manifestations of addiction in terms of what it, which has commonly in the past, unfortunately, been called resistance, which is in fact different manifestations of the trauma response. So if someone has had a traumatic history with asthma, for instance, whether it was a parent or themselves, and I'm going to offer them breathing and not much else, that person is not going to get what they need. So one of the other things that we have in our training is the first question we ask people, what are your strengths and resources? It's finding out what they already have, right? That I don't need to assume that I'm going to have to give them a calm place. Maybe they already go to the happy place, right? And finding out what it is that they already have, and then, hey, show me that. And what has happened for me over time is that I have a larger kit to offer my clients, because I've had clients come in and say, I do X. I'm like, oh, show me X. I've never seen that before.
Like we have people, if you have a breath skill, if you have a prayer, if you have a song, a playlist, you like, show us that. And just based on some of the commentary I'm seeing in the chat before we move on, please remember, resourcing is a broad spectrum term. It's not just this thing of like resource figures or resource exercises. Those can be resources, but everything we're talking about here with mindfulness skills can be resources too. So go ahead.
Can I go back to phase one then with that?
Go for
with
it.
that thought is that when we're looking for resources with an addiction client in the treatment center, that includes what Jamie, did you coin this phrase? The recovery capital.
It's not mine, but I use it a lot. Yeah.
Yes. So recovery capital, like the fact that that person goes to meetings, the fact that that person has a church group, the fact that that person has like 5 tight friends, all of those, it's not just about resources in the office, it's resources in the office, outside the office, it's skills, it's also relationships, it's everything.
And this is something that I think recovery culture can contribute to EMDR, because in 12-step world and addiction treatment world, we've been used to this, like looking at, hey, what works? Let's get it together. And that was Granfield and Cloud, 1999, who developed recovery capital, just for the sake of the citation. Sure. Yeah, it's a great term, and it is very analogous to resourcing, but I think it encourages EMDR therapists to look broader than just the 3 visualizations and the 3 resource figure exercises you may learn as part of your training.
Can I also reflect on Andrew Leeds and Deborah Korn's resource development and installation protocol?
You can reflect, but I'm going to comment. And I love them both, it was a major contribution to the, go ahead, reflect, and then I'll respond.
Okay. So I'm just reflecting upon it because that's kind of where resource figures came from originally.
Yeah.
Right. Which is, how can we, one other way of helping people to get to some resources is to help them visualize from the point of view of their own lives, of role models. And when I say role models, I don't mean who you want to be when you grow up, but, identifying resources and then identifying people who exhibit those resources, coaches, and then symbolic or spiritual, metaphorical, right? And
for sure.
And so I, honestly, I have found, I'm being honest all the time, by the way. Honestly, I've used RDI a lot in the past because it's just been very helpful for those folks who can't find anything. It's a great starting point, and just also it provides them with resource figures, perhaps, that may or may not end up being a major part of their resource toolkit.
And here's my issue with RDI, to be clear, like what RDI did in the history of evolution and of EMDR cannot be understated. I mean, it really opened up this conversation around resourcing is more than just one calm, safe place, because that was how it was originally taught. And RDI gave us a real model forward for anything can be tapped in, eye movement and toned in as a resource. I think the RDI protocol as it's written can be a little overly technical, and that can trip up a lot of new EMDR therapists.
100%.
But for those of you who really need a step-by-step instructional guide, it could be a really good start. I mean, my tendency is more in phase 2. If you are using a resource that is engendering some kind of either pleasant or neutral experience, okay, notice that, feel it into your body, tap it in, just give it a couple sets. And I think sometimes with the actual RDI protocol as it's written, it can get a little too clunky.
And more reflection, just in terms of the broad strokes, is that, when I did those interviews with Andrew about EMDR in general and asked him about RDI, he revealed, and we have it in I think both books, he revealed that protocol was the result of a long-term treatment failure.
Yeah.
In as much as he was having no fun time helping a person to have any resources. Right? It was a intractable depression case, and it just nothing. And then one day she had a dream, and it had a positive image in it, and he's like, "Oh, notice that." Yeah. Right? And so that's the core of it.
Exactly.
And that speaks to your point.
And that
it
I'm
sort
all
of
for.
Open the door to like, hey, it's all resources. If it speaks to the client, then it's a resource.
Right. So I'm glad we're talking about this, because I'm getting another really good question, which is, what about other structured curriculum like Seeking Safety? Of course. And to that point, if you're on this Facebook page, Mindful Ohio Institute for Creative Mindfulness, if you search my YouTube, I just interviewed Lisa Najovitz literally last week. She's a good friend of our work, and I've gotten closer to her in recent years. And yes, she did the EMDR training with Shapiro, so she's a friend of EMDR, and several of the more structured studies on EMDR, specifically the Gilman and Brown drug court study. Seeking safety is what was used as part of the preparation. And something that we want to talk about as well is, and we teach this in our training, in phase 2, particularly, EMDR therapy plays well with other therapies. And seeking safety is a prime example of that, because she really wrote that curriculum from this place of being both a trauma and addiction specialist, bringing them together. I mean, I argue that the 12 steps, if somebody's really invested in a 12-step program, can work as part of phase 2. Any other structured recovery program, DBT, dialectical behavior therapy, works really well as part of phase 2. So yeah, I think part of it here is really, to quote my friend Mark Brain, unleashing your EMDR to think outside the box in phase 2 and really be open to bringing in anything that's going to help a person.
And that, so far in my experience, I incubated working in this way in 2 treatment centers for about 3 years, and now have been working with a number of treatment centers since then, since 2019. That is the way it looks.
Yep.
That's the way it works. We don't say to, our team doesn't say to the treatment center, here's your mindfulness program or here's your resources. We say, what are the modalities that you're already using, or what are the modalities you want to look into using as part of the different many opportunities that clients will have to resource to get their phase 2 and their phase 1 needs met.
So we'd now like to segue into phase 2.5. So to be very clear, this is in no way connected or affiliated with what you may hear of as EMDR 2.0 and the work of De Jong, which is like a spin-off of EMDR. EMDR phase 2.5 is a term Steve and I kind of coined separately yet together to talk about this bridge between phase 2 and phases 3 through 6, which we see as the reprocessing phases, where you're really setting up a memory and going with that. So 2.5, how I really see it is, it's kind of like mega resourcing, where you're introducing an element of greater distress tolerance, perhaps working with something like craving. So even how we describe mindfulness of craving, having a person practice sitting with their craving for a moment or two, that could be a 2.5, because you're introducing this idea of, all right, let's titrate or ease you in to the process of feeling greater affect. So 2.5 involves obviously the conversations that you need to have with your client collaboratively about, are they adequately prepared to at least try doing some phase 3 work, knowing that at any time you can come back into phase 2 if more is needed. EMDR phase 2.5 can be talking about EMDR playing well with other techniques or other spin-offs. The flash technique, which is very popular and very embraced now in the EMDR community, I think that is very valid when you're working with any EMDR case for a person who needs to have a greater degree of containment and titration. I see flash. I see some uses of detour potentially being 2.5, because a person is not adequately prepared to take on a full trauma memory, let's say, but they do have the willingness and readiness to work on their craving. And that's where you could bring in a 2.5. So those are some examples of what we mean by 2.5. And then I even go into the book, and this is in some other elements of my work. 2.5 can also be, let's say you're at that kind of sweet spot of, I'm not sure how they'll do with doing a full standard protocol EMDR target phases 3 through 6, but they seem to be doing well with their prep resources. They have the willingness. You can go into a phase 3 setup like you normally would, but instead of asking what is the worst part, what image or other sensory detail represents the worst part, You can also ask it as, what part of this memory are you willing to work on? Because one of the criticisms I will tell you of EMDR from other trauma methodologies that work more with titration is that we shouldn't be taking people into the worst. And obviously EMDR therapists would say, well, you're getting at the source. So of course you would. But I think we can have some room to say, which part are you willing to work on? So I might not be able to work on the deepest part of the fire, but I'll work on one of the flames. It's a bad metaphor, but it's just what came out. So you can ask, are you willing to work? Which part are you willing to work on? You could set up the target as such. Sometimes it may process through to completion. Other times you may have to go back and then check it with the worst part, but there's usually a greater sense of efficacy built that, yes, I can do this. So a lot of what 2.5 is working with the middle ground between phase 2 and phase 3. So Steve, why don't you reflect on kind of what 2.5 means to you?
Well, in addition to that, it really means this sort of fruition of the collaboration between me and the client. That EMDR therapy is a very collaborative therapy, and that when we're in phase, what we call phase 2.5, we're now at the juncture where it really has to be collaborative, because we're deciding together if we're prepared enough, if the client is prepared enough to, to continue forward. So it harkens back then again to the phase 1 work that we've done and the phase 2 work we've done, but particularly phase 1 work, where if we've taken a really, a very robust client history, if we've farmed a lot of targets, we're probably going to have farmed a lot of targets at a lot of levels of like pain and acuity or difficulty. And then we can work with, then we have a list essentially when you're asking that question that you just said, described asking, like which of this are you willing? Which of these targets would be a good place, would be the right portal for us to go in? And some clients are like, that thing, that's the worst thing that ever happened to me. And then other clients will be, like, can we do that thing with the hangnail and take it from there? And then there's like the whole middle ground. But again, this is going back to standard protocol, well conceptualized. What you have there is, if you have it well conceptualized and well done, the phase 1 work, then you have everything there you need to do 2.5 in a way that finds that, like you said, sort of that middle path. Or
nice. Yeah. So another part of 2.5 is then also asking the questions about, are they adequately prepared to go on to phase 3? And probably one of the biggest questions we get as consultants is the person ready? I hate the word ready. It's a little bug I have up my butt about that word. Because let's just say I've dealt with a lot of people in my life who use the whole "I'm not ready" as an excuse. And my counter to that is often, well, what are you doing to get ready? And, I want to be sensitive to realize that if a person's saying they're not ready, I don't want to totally jump in and deny their reality about that. Yet I tend to address it with, are you willing to prepare yourself to even be ready? And that's where, again, I like how she named phase 2 preparation. So yes, we get the question a lot. Is the person ready to move into phase 3? And we cannot give you a perfect answer. And if any EMDR teacher or consultant out there says they have a perfect answer, please be skeptical, because it really has to be evaluated on a case-by-case basis. So, as we train, and this is in all of our work, it's really a series of questions you need to evaluate qualitatively. Is a person using some of the skills you're giving them? What is their motivation for change? And having external motivation factors is not all bad. I mean, there's treatment literature to show that whatever gets a person in the door, it's a good thing. What is their depth of recovery capital? Have you addressed secondary gains and other issues? Some other questions we might ask. Help me out.
I don't know why I'm blanking, but I'll find it.
Looking at lifestyle issues, yes. Like, can they call somebody in between sessions? Do they have access to reach you? What is your protocol for being contacted? Have you and the reason we do such a thorough phase 2 is so that you have those in place for phase 7 to be able to handle closure adequately. So it really is something that has to be negotiated case by case.
And also phase 8, they're part of phase 8. They're out in the world being a free range chicken, and do they have the skills or the necessary resources to be able to provide enough of a container for themselves until the next session.
Yep. I got a really good question here that I do want to address online is blind to therapist 2.5. And any kind of work with blind to therapist is when the client doesn't feel like they want to tell you what target they want to work on or give you details about it. It's just, okay, I have it in my awareness, let's do it. And I think it has some 2.5 qualities to it, but I've always seen it as more it's just the standard protocol. We're just being open to more variation with it if a person doesn't want to tell you. And I think the only caution I would have about doing any blinded therapist work is to make sure that you have your stop signal in place, to make sure that all these other safeguards are in place that we've discussed, because I have done blinded therapist work and it could be phenomenal. And usually afterwards, then the person's able to tell me what they worked on, give me a little summary of how it came up. Anything else you want to talk about, Steve, with the bridge between phase 2 and phase 3? In the treatment centers, how do you make these kind of decisions?
So again, going back to the idea of, what a wonderful place treatment is to do this, is that, the therapist doesn't have to do it alone in a vacuum, or that's not a vacuum, but they don't have to do it alone. Of course any one of us can get consultation at any time. But yeah, treatment team meeting is a lot of the treatment team meetings are phase 2.5 meetings, right? Is this person is this person prepared? What are the concerns, etc. And then also I just want to also say about the sort of maybe what we're looking for, like big picture, what we're looking for preparation is this, and for 2.5 is the sense that basic safety, basic safety plus is taken care of, because then we can help usher the person into their first phase 3 through 6 experience. And if they need to back off, if they need to take the foot off the gas or hit the brakes or whatever, now we're in, and now they have an experience of it, and we maintain safety. And if we end up not doing another reprocessing session for one or several sessions, it's not a problem. It becomes part of what this is, which is a process.
So let's talk about now phases 3 through 6. And Steve, why do you refer to it as Shapiro's special sauce?
Well, of all the things that EMDR therapy is, that's the most, scripted. That's the most, I can see her in her workshop going, how do we get, from here to here? Phases 1 and 2 and phases 7 and 8, although, it's interesting to me because I've spent so much time as an EMDR therapist. I don't think of a lot of, I know a lot of therapists come to us and they're like, the last 10 minutes are about resourcing, and like that's how we do it. It's like new. But phase 7 and phase 8, phase 8 is so much about treatment planning, the same way that one might treatment plan, and so anyway, point being that 3 through 6 are the most uniquely, to my mind, Shapiro just discovering something or putting something together out of wonderful parts.
Well, I think 3 through 6, and we even addressed them together here. Obviously, assessment of the target, desensitization, installation, and body scan. That is what's probably most known to the public as EMDR therapy, even though, as we've emphasized, EMDR is all 8 phases. And to bear in mind that how you approach phase 3 through 6 with somebody who's struggling with an addiction or compulsion is largely informed by how well you've done phases 1 and 2. As we mentioned, with case conceptualization, with target selection in phase 1, a lot of what well conceptualized means is engaging in a good order of operations here about which themes, which targets you're going to be going at first. And Yes, I know, especially if you've been trained traditionally, a lot of what we get is go back to the first, go back to like the absolute touchstone here. That's how you get to the root of everything. And to me, it's a both and, because on one hand, I don't disagree that that might be the most powerful way to bring about the greatest degree of generalization. You must acknowledge that with people who are struggling on a daily basis, who may not have the luxury of doing this in a treatment center, who may not have the luxury of doing this as part of intensive model EMDR, much of what recovery is going to mean for them is learning how to deal with stuff out there in the 167 hours of the week they're not seeing you. So that's where you may have to approach a little more cautiously than just going back to that absolute first touchstone. So it could be, let's say, working with the recovery roadblock. And you can look up this demo. If you're watching this on the recording, it'll be spliced into the course. You can see that case I mentioned where we worked with her fourth step recovery roadblock. That's what we did really first. And then once we did that first, we were able to look at some more of the what we might consider to be traditional trauma targets. So going back to high school math, if you remember this phrase, order of operations, kind of knowing this is what we should probably do first to get the best impact overall, that becomes very important here if you are going to use standard in the treatment of addiction, is knowing what order you're going to target in. Is also knowing that you might start one target and a person gets blown way out of their affective or wheel of tolerance with it. And it's like, okay, let's put this on pause, put it in the container, but maybe some other manifestation came up during your work on that target. And that becomes where you would need to target before the original one you worked on can be addressed. So I think it's also important to keep a listing of your targets as you're moving into 3 through 6, comparing them to the treatment plan, and get consultation. If what I'm saying to you sounds like, I need it more linear than that, get consultation. I mean, personally, we have tons of people in our group who are used to thinking this way. You may have people you already work with for consultation, but it's doing EMDR continued development with folks who have had to solve these kind of puzzles before that I think will really help you get good at making a lot of these decisions.
And then looking at what you were just saying about what comes up in phases 3 through 6, that then becomes, I call it a phase 8 issue, right? Like the target is, when we come back the next session, it's like, do you want to keep working on that? No, I don't. Okay. So then we're looking at the link between phase 8, that which happens in between sessions, and then phase 1, just linking it back to phase 1. Phase 1 is a living, breathing list, right? There's often new, like we're not done. Oh, we've done phase 1 and now we're reprocessing that which was there and we're crossing things out. It's new stuff does come up. Sometimes it's a little, sometimes it's a lot. And we're adding to that list. And we're also finding ourselves, let's say we reprocess a target, we find ourselves through generalizability, crossing out, multiple things, right? So it's having this more, again, yes, less linear, more sort of holistic vision of what's happening as a result of phases 3 through 6. When we have especially like an incomplete session, right, and we don't get down to a zero, we don't get zeros and sevens and puppies and unicorns, and we come back the next week, and that person, I'm glad you did the math. I'm always saying 6 days and 23 hours of time. I find that that's the time where people are doing a majority of their work, right? Like, we're not in some kind of weird magic land where it all happens where we are and it's supposed to happen where we are. We are like this facilitator of this amazing, supercharged process that then continues on in between sessions and minute by minute, moment by moment. And so I find so many of my clients, like they come back the next session and it's like, so 0 to 10, where's that thing? And they're like, 0, right? Or no, I'm still blown out over it. Do you want to work on that? I can't work on that right now. Okay, let's look at the phase 1 list and see, what we can do. I don't want to do that. All right. Okay. So let's You want to talk?
And in those circumstances, a good question I often use is, what are you going back to my 2.5 thing, what are you willing to do today? And this goes to, I'm going to open up a can of worms here, but it's what I do. I'm the worm can opener. And it actually relates to a question that came up a little earlier, but it wasn't the good time to answer it. And I want to talk about some technique issues. Because obviously, Stephen and I emphasize good technique in how we train it. We want you to learn the SUD scales, the VOC scales, 0 to 10, 1 to 7. Again, if you're doing kind of purist Shapiro here, you want to finish what you start in terms of targets before you open up another one. And so as I feel about standard protocol in general, you want to learn the rules so that you know how to break them elegantly when you need to. But if you don't learn the rules, you're just going to come across as amateur. So some places where you may need to technically break the rules is like what Steve just said, or not break them, be artistic with how you implement them. That yes, technically you shouldn't move on to another target until you finish the one that you were working on, but you may have clients who come into your office that day who are just not in the space to work on this particular issue today. And of course you can, try to make a pitch for how you can be helpful and supportive, but I have done a lot of target jumping with clients because they're only willing to work on this one thing today. And so as long as you keep a list, and it is a both and, like, you want to be mindful not to have 85 targets open at one time, because I think that can get chaotic, but to realize that not everybody is going to follow perfect technique. As one of my colleagues says, life isn't scripted, neither are people. So it's good to have the scripts and to know your technique, but to realize where you may need to play a little bit. And then of course I got a question about what if people can't handle the 0 to 10, 1 to 7, that scaling, numbering just isn't for them for whatever reason. People may feel like, well, I'll never get down to a 0 because of a disability I'm struggling with, because of the fact that this happened. I want you all to remember this first about 0 to 10, because I've made peace with a lot of these number things in my EMDR career. Because when I first got trained, it was like, oh, these scales, especially 1 to 7 with the VOC. Couple thoughts on that. Please remember that 0 on the 0 to 10 scale can mean neutral, because we typically ask 0 meaning no distress or neutral. So if you call something a 0, it just means that the charge might be there. Like it may still technically bother you because it happened, or because this is the life state you're working in. But in this moment, as it relates to this issue at hand, I can call it a 0. And then if people get so caught up in the numbers that it becomes a deal breaker, you can play. I mean, Howard Lipke, who was one of my mentors coming up, he was my approved consultant. He does a lot of work with veterans, and instead of being married to the 0 to 10 scale, and Howard was around in the beginning days when things like that were developed, he'll often say, well, what would you prefer to believe instead? Or not believe, but what would you prefer to feel instead? And maybe we take the numbers out of it and work more with that. And another way I've made peace with numbers, and Steve and I feel very strongly about this, is when you're doing the phase 3 protocol setup. One of the modifications that often gets made is skipping the positive cognition and the VOC. And honestly, in a lot of early days of my formation, I kind of had some of that feeling too, like, oh, the positive cognition isn't that important. And yes, if a person is struggling to even come up with one in phase 3, if they can't even wrap their head around a VOC, that would probably be the one I'd be most likely to skip and still, get enough activation to start phase 4. But why I find it has become incredibly important to ask for a positive cognition in phase 3 and get a VOC as best you can, even though the scale can be a little bizarre, is it is intention setting. And I'm going to have Steve talk about this a little bit more. This is where an area where I've really made peace with the standard protocol, because there tends to be, for people who don't like the PC and the VOC, this will just activate them and go. Yet the more complex trauma, which is often dancing with addiction here, and Howard actually helped me to understand this, that by asking for a PC, you are engaging a little bit of titration. instead of just like pure activation and go, where a person can be maybe too easily overwhelmed, by asking them to consider, what would you like to believe instead? Or a word Shapiro used in the early days that I sometimes lean into is, what would you prefer to believe instead? You are getting the person up into their thinking head just a little bit to be able to kind of slow down an intense activation that might be coming up. So it is titration. And from a mindfulness and yogic perspective, having a person identify a PC is intention setting. It's positive treatment goal, if you're thinking of detour terms. And there's so much that's been written in yogic scripture, in the dance therapy movement world, about how even when you set an intention, you're already rewiring your nervous system, your neuromuscular system for change. So in talking about standard protocol in the treatment of addiction, we really feel it's important to highlight that point. Do not skip the PC in phase 3. Knowing it can change when you get to phase 5, and in most cases it will by the time you go to install it. Steve, I know you have strong feelings about this.
Oh no, I have no feelings about
None whatsoever.
So the other thing besides what you're talking about, how it's setting an intention, it also actually is, as far as I'm concerned, especially with people with addiction, part of the activation. Part of the activation is many people with addiction, many people with trauma, but many people with addiction, when confronted with the positive, that's part of the cognitive, for lack of a better term, hell that they're in. So, it can go either way. And in either case, it's important that it is part of the activation, it is part of intention setting. And I don't see the problem with, quote unquote, putting them up in their head, because this is a therapy that is top-down technology and bottom-up. This is a therapy that acknowledges that the difficulties are not just in the body and the limbic. That's where the stuff is stuck, but there's all kinds of cognitive mess that is part of how it has been maladaptively processed. And so finding all those aspects of the cognitive and then moving to the limbic, as the phase 3 does, and then finally to the body, the thing that's most outside the consciousness, is a wonderful way of, as I heard at an EMDR conference once, providing kinder, gentler exposure in very short order, and then moving, getting them out of Dodge. And so yes, I have strong feelings about that. We put that in the, I don't know if that's in this book, but in the EMDR Therapy and Mindfulness book, we address that that the PC and the VOC are actually another source of activation.
Yeah. So phase 3, phase 4, phase 5, we've all touched on here. Phase 6, body scanning. Think of how we advocated its use in phase 2. And the more you prepare a person to answer questions like scan your body from head to toe, all I'll really say as a comment on phase 6 here is, if the first time a person is hearing scan your body from head to toe, what are you noticing now, is in phase 6, it's probably too late. Like, you want to prep them for that in phase 2. And the body will reveal a lot. When people ask, well, what if a client's kind of lowballing you or telling you what you want to hear with your phase 5 check-in or your phase 4 check-in? Oh yeah, the SEDS is a 0. And it's not to say that they're immune to lying about what's happening in the body, but often body scan is about us as therapists using some of the nonverbal reads that we can about what a person's holding or locking in their body.
You just brought up another psychoeducation note. Just I want to going back to the VOC, the PC and the VOC, is that psychoeducation is like, I don't know, I'm not gonna make up a number, 80% of this therapy, right? Like, the more I prepare a person, the more I make them an expert at this process, the better it goes. So that's another psychoeducation point. I spend a decent amount of time before moving into phase 3 teaching them a little bit about how phase 3 is going to go. Just letting them, like I don't surprise them with the setup. They know what the setup's going to be. And usually what happens is, sometimes, not all the time, first time, maybe second time, it's kind of wonky. I don't understand, I can't find it, or I'm having a hard time. And then they have it. And then we have a flow. Right.
And part of the psychoeducation, and admittedly, opinion is split on this about whether it's good to show a person a demo, of which we have many now. before they go into phases 3. I mean, I think some therapists have a fear showing a person a demo gets them too much in their head, too worried. I will say I had a long-term former client who now follows my work on YouTube, and he said, Jamie, if I would have had one of these before I started, I would have been much more enthusiastic about doing this. So I do think preparing people what to expect, however you do it, at whatever degree you do it, and a lot of that has to be read client to client, is very important. So let's spend some time talking about closure and reevaluation, and I want to touch on future templates as part of that too. And then I want to leave some time at the end here as we conclude for Steve to talk a little bit about the palette of EMDR interventions and how that ties into some of his treatment center work. So phase 7 closure, I don't think there's much more we can say on it other than some points we've touched on already. That one of the reasons we do phase 2 so well and so comprehensively is so that we have skills people can draw on in phase 7 closure. And particularly when you are first starting phase 3 through 6 work with people who identify as having an addiction or compulsion, you want to allow a good amount of time, at least 10 minutes, to really account for closure, which can include containment, using the skills to get them in a good enough place to go, reviewing what they can use in between sessions, talking about what could happen, not what will, but what could happen in between sessions, and developing a plan, and really seeing phase 7 closure as part of the idea of honoring transition. So anything else on closure I may have missed?
No, just I like the way you ended that, where we're not telling them what's going to happen. We're telling them what could happen.
Yeah.
And allowing the client to, depending on what phase or what stage of the therapy you're in, and whatever your protocols are for, being available in between sessions, making sure that it's very clear at the end of that. But otherwise, for me, I say to my clients, dealer's choice. What do you need in this last 10 minutes to
for sure.
transition?
For sure. And I do believe that, and this is where I think our 12-step recovery as a lifestyle influence impacts how we do phase 7. And talking about preparing people for what could happen, it's not to say like you will have craving, but you may have craving. And if that happens, you've not done anything wrong. But here are skills you can use. Because I got into a debate with another EMDR therapist once about, the purpose of EMDR is to eliminate craving altogether, so it's never an issue. And I kind of laughed at him like, ha ha ha. Because all these years into our paths, we can both still struggle with craving, but the issue is it's now we know how to more effectively deal with it. And so I think a lot of phase 7, and thank God cravings are fewer and farther between, but so much of phase 7 is normalizing the idea that life is a relapse trigger. And how are we reviewing, these are the skills you can use when that happens.
And this is also a long-term recovery issue, is that like the last craving that I had was like over 25 years ago, like a craving that was just like must drink now. What I have are similar feelings of wanting to get out of self. They just don't go towards the substance anymore. And if I don't help my clients and myself to address that will eventually turn into my finding a way out of self that may or may not be adaptive, and or it could allow for for it to go back into craving mode. So this is part of phase 7, phase 8, ongoing relapse prevention, ongoing long-term recovery.
For sure. And so phase 8, let's wrap it up there. And we've touched on some phase 8 points, of course, throughout. And I really see the EMDR phases as being very circular. That it's not, okay, we've gotten through the 8th phase, we're done, congratulations, you have won at EMDR and at life. And this is where I think there's a lot of parallels to the 12 steps, because the 12 steps were not meant to be worked just one and done. That part of ongoing 12-step work and in steps 10, 11, 12 is ongoing inventory to know if you need to go back and do any of the other steps. So same with the EMDR therapy, that phase 8, and we talk about this in our work, happens at both a micro level and a macro level. That every time you're checking in session to session, you're doing some kind of phase 8 work. And Steve spoke to that a few moments ago, whether it's, okay, what are we doing today? Where's this going to go today? And of course, at more of the macro level, it's the treatment plan review. Like, now that we've worked on this one issue and these series or this cluster of targets, where do we need to go next? And that's where, once more, having the comprehensive oversight is important here than just EMDR being a series of targets. We also teach very adamantly that future template work should be done throughout the EMDR treatment, because there are some models of working with future template, which is you do all the targets on the table first, and then you set up future templates. We have largely felt that once you do a piece of targeting work, if there is a natural future template that goes along with it, do the future template then, and that may better reveal where you need to go next. So a common example may be, let's say it's difficulty emotionally you've had with your mother's alcoholism, because in our book and in our work, we do give a lot to how a lot of these same principles of working with people struggling with addiction and dependency can also apply to family members, to loved ones. With the word codependency, that's traditionally been used, although even that word has come under some fire for not really being trauma sensitive enough. And a word like prodependence has been used as a suggested replacement. Again, you could read more about that in our work if that interests you. But let's say, and this is an example of where there may be a good natural future template, you're doing some EMDR reprocessing 3 through 6 work about how your mother's alcoholism affected you as a child. You may know that next week you're going to a family gathering where your mother is very likely going to be doing shots and being superficial. So why not set up that future template immediately? Because this is part of the idea that life is the relapse trigger. Life is going to be continuing to happen. Then of course you can go back to traditional targeting work, but we really see that future templates should be woven in throughout. Steve, why don't you comment on that? And I'm going to look at some questions here.
Yeah, just the future template, the way that we train it, we do it, it's basically taking leveraging the successful processing of a past target to get right to the future template and have that reprocessing happen, often in much shorter order than it would be otherwise. And keeping in mind that Shapiro's protocol includes also the 3-prong protocol, past, present, future.
Amen. Yeah.
And that we're not done with therapy until we've done, all 3. Why not? Since we're not all about like, how can we speed this up? But, how can we leverage some successful reprocessing of a past target into successful reprocessing of a future template in short order? So again, it really goes back to taking a fresh look at phase 8 and phase 1 in a more holistic way. And I want to address something you said earlier about, having too many open targets. My suggestion in saying, what are we going to work on today, is not like an issue du jour, let's try something else kind of thing.
Whack-a-mole EMDR, yeah, exactly. Is sometimes called, yeah.
That was, Andrew, when he trained me, he said, issue du jour. It's not issue du jour therapy.
Right.
And so the premise is like, we're both, myself and the client, we're looking at the treatment plan together and seeing where we can go today. And, and so when it's done that way, and then another phase 8 piece is when when a client says, I don't know where to go, or where it's obvious it's time to kind of take a new direction or a new phase, is doing an assessment of gains together.
Oh, nice.
Like using some time to assess, hey, let's look at how far we've come, because that, number one, that's great. I think for the client, empowers them, makes them see kind of where we're going and how they've actually gone somewhere. And then that gives a fresh look to the rest of what needs to be treated.
Amen. So we got a question before I have you go into the palette and some of the work that you do in treatment. It's such a good question. I want to address it on the air here because I think it's a good one to wrap up. And the question is suggestions for helping clients sit in their feelings after sobriety so that they are not triggered. This can be a new concept in the beginning. So one of the things I want to take on, and of course, as a client might struggle with this, I try to handle it as sensitively and as meet them where they're at as possible. Remember what I said a few minutes ago, life is a relapse trigger. And even though I'm glad there is more language and awareness around this concept of triggering now, especially in the general public, I am afraid that some of the discourse has led to, well, how do we keep people from being triggered? As opposed to how do we help people handle their triggers? Because life
Mm-hmm.
is a relapse trigger. Life potentially is a trauma trigger. And I think one of the greatest gifts we can give to people, both in addiction recovery and trauma recovery, is to teach them how to sit with feeling, whether it is pleasant, unpleasant, or neutral. And for so many people, the reason that is difficult is because they're carrying a negative cognition, like I cannot show my emotions, it's not safe to feel my feelings. So some of your answer, depending on the client, might be you set that up as a first target when you're in the 3 through 6 work. What is your block even around sitting with distress? But part of the both and with that can be like mindfulness of feeling tone, which I'll have Steve talk to a little bit, giving people it's what DBT calls distress tolerance, but giving them opportunities to sit with distress in as safe as possible of an environment for little doses, and then be able to debrief it with you and then come back to one of their other skills when it's through. So more on that. How do we really work with distress tolerance?
So that's what I love about the way that we work with this, in as much as really leaning into the implicit and explicit mindfulness elements of this therapy, and seeing it as, an 8-phase protocol, seeing it as a 3-stage model of trauma treatment, that the mindfulness is woven throughout the process, which includes, if I'm hearing the question correctly, on the far end, when treatment is either completed or we're coming towards the end of treatment, and how do people set up a lifetime practice of distress tolerance. So going back to what we were talking about early in the program, is giving them whichever distress tolerance, mindfulness based or otherwise, exercises, skills, abilities that allow them to make it through the early stages of recovery, then continuing to support that, like not making it into, this is not something that just kind of made you ready to do this. This is something that can last you a lifetime. And then also working, here's another thing we've been talking about, how phase 1 list changes over time. Phase 2 list changes over time sometimes, right? Like resources that I was using before they're not the right ones now, and here's a new one. Or I need another resource to deal with this new difficulty that I've discovered through doing some of this process. And so I have to add a resource. And so a lot of times when looking at it from the mindfulness based perspective, that's where a lot of the distress tolerance comes from. And helping people to understand that this is not just like part of their treatment. This is a possibility for a lifetime.
And let me share with you an intervention we use from expressive arts therapy. There's many ways you can teach distress tolerance. This is one of my favorites that is potentially the least threatening. Work with people on listening to songs they don't like. We're not talking about songs that extensively trigger you and bring up memories of your trauma, but everybody right now, think about a genre of music you don't particularly care for, or an artist you don't particularly care for. It used to be the Eagles for me, but now I like them from doing so much of this exercise. So take that for what it's worth. So think of a genre or an artist or a song you don't particularly care for, and just challenge yourself to listen to it. Maybe, and if you want to take this exercise a little further, you listen to a random playlist that your music service gives you, or if you still listen to the radio, just listen to the radio and challenge yourself for 20 minutes not to change the channel. Because to me, that's a metaphor for life. You can't control what's going to come on the playlist. So what would it feel like if you can just practice listening to songs you don't like, breathing through it, using some of your other movement skills through it, or just sitting with, I also think waiting in line at a store can be a good way to practice this skill, and really working with people on the reality that so much of what life is about, let alone recovery, is having to deal with things you don't like. So
Even looking at the historical Buddha's first teaching,
Go on.
The teaching of that life contains or has dukkha, and dukkha can be translated as most commonly as suffering, right? Which brings up thoughts of old age, sickness, death, things like that. But the other translation is unsatisfactoriness. So we all get to notice, that it's more a continuum. Like, I'm not getting in the frame here. My mechanical reasoning skills are off. So anyway, but that, yes, lots of life, if not almost all of life, is potentially unsatisfactory.
I've joked with Steve before that, how so many treatment centers have names like Whispering Pines and Serenity Center? I'd like to name a treatment center Dukkha.
Yeah.
People think it has this great fancy Sanskrit name, but so much of it is about how to navigate that. Well, we have just about 10 minutes left. And Steve, you don't necessarily have to go into all the detail about the palette, but perhaps just a little bit about, now that you have all these different tools, which are really kind of empowered by the standard protocol, how do you make some of these decisions, especially if you are doing mainline treatment?
Okay, so in the treatment centers that I'm working with, what happened was back in 2015 or 16, whenever it was that Jamie and I were starting to talk about my coming on as senior faculty or as faculty at the time, I was helping to open a treatment center, and that we were going to use Buddhist psychology and Dharma as the main focus. And shortly into that, I was like, why wouldn't we also use EMDR therapy as a central focus? Why don't we use EMDR therapy, the 8-phase protocol, together with mindfulness as a way of framing treatment so that treatment becomes trauma focused? And so that's where I developed mindfulness and EMDR treatment template for addictions. And so it's now for agencies in general, but it was born out of addictions. And the idea was that treatment centers, by their nature, are providing phases 1 and 2 of EMDR therapy, right? We're getting a history, we're building rapport, we're stabilizing, we're preparing. We're just preparing them for what? Fill in the blank. Preparing them for sober life, preparing them for all kinds of things. Why not have it be about preparing for the rest of their trauma therapy journey? And that some people in even a residential stay might go through phases 3 through 6. And in essence, actually, people are getting phases 1, 2, 7, and 8 of EMDR therapy when they're in a treatment center. So we're just kind of filling in the blanks and making it central. And so what we've discovered by doing that, it was also to say, well, what if we had the meta part, because it's meta loving kindness, METTA, and then the other is meta META, using a meta vision of the 8 phase of Shapiro's work. And what that means is that everybody on site gets some kind of trauma-focused training. They don't start waving their finger in people's faces, but everyone in the C-suite, everyone who's line staff, everyone's getting trained to support this idea that we're going to bring people through a course of trauma therapy. And so what comes out of that is that we're able to do EMDR therapy with people in a treatment setting. And also we're finding that taking a trauma-focused approach brings the healing that is described in the literature along the lines of trauma, and then along the lines of PTSD, and then along the lines of addiction. And so not long after we started doing that as a team, the palette of EMDR interventions in addiction came out from Marcus and Hornsfeld I guess they're in Amsterdam.
Yep.
And what they did was they did a literature review and looked at all of the interventions described in the various specialty protocols and in the standard protocol that are specific to addiction. And they identified, I forget the number right this second, but like something like 16 or 17 interventions. And
15.
what that 15. Mm-hmm. So what that did for us, and this is really for me, Jamie, all the folks who work in our way, we saw that some of what can be done is described in module 3 trauma-focused EMDR for comorbid PTSD, and then module 4, trauma-focused EMDR for emotional problems in clients who don't have PTSD but with addiction, and module 5, patients with debilitating negative beliefs as they pertain to their addiction. And basically what that is saying is standard protocol, right? That these are 3 modules of the palette of EMDR interventions in addiction, which in our model in Meta Protocol, we just choose to make those 3 core pieces, and that everything else is there to support that. For instance, the first 2 modules are Calm, Safe Place and RDI. And then what A.J. Popke most famously brought to the table, which was the installation of the positive treatment goal, which is, a wonderful and critical, and I love the way that he presented it, which was that positive treatment goal does not have to include abstinence.
Correct.
That just opened the door for all sorts of folks to get help for their addictions. And then those next 3 modules, which are our focus, which is just providing standard protocol as a core way of dealing with things. And then there's a whole host of other specific modules using flash forwards and memories of relapse, memories of craving, positive memories. Like you said, Jamie, I'm not going to go step by step through this right now. But all of this adding up to basically seeing this as a holistic process. And so the folks who Marcus and Hornsfeld and their team, I think they've manualized this, right? In other words, they use this now as their structure for treatment, and it bears many similarities to what we're doing. And what we're doing is we added, and this is in our book together, Jamie and I, is module 2.5. How rare that we have another 2.5, but it's basically seeing Calm, Safe Place, RDI, positive treatment goal, and 2.5 is mindfulness-based resourcing and preparation strategies.
Yes.
And that is, again, that's Jamie and I, when we met, that was where we met, was on the field of mindfulness and the field of trauma care and the field of addiction care that is trauma-informed, and not just trauma-informed, but trauma-focused. And so that addition of the mindfulness to this palette, I love this work that they did.
Yeah, so I think the palette is cool, and it shows you all the ways you could use EMDR in treatment. If you have access to the Journal of EMDR Practice and Research, this article was in there in 2017. It is highlighted in our new book, Healing Addiction with EMDR Therapy. And as the expressive artist, I have to comment here that when I think of palette in an artistic sense, you can have these 15 modules as 15 different dabs of paint on the palette, but we blend on the palette.
Yes.
And a lot of that, how artists work, is following the flow. But if that's grounded in the good technique,
yes,
you'll be in a really good place. So, Steve, any parting thoughts kind of on the formal content of today's workshop, the standard protocol in the treatment of EMDR therapy?
Well, I'll just say what I say to my trainees, which is, I have my own, we all have our own particular experience with EMDR therapy as clinicians. Some of us get trained and it becomes part of our repertoire. Some of us get trained and it was like, that was good information, thanks. Some of us get trained and it becomes a huge part of things. And then for some of us, like in my own case, it becomes the core and the heart of what we do. And so coming from that place, I can safely say that for the past 15 years or so, I've been treating addiction with the standard protocol at the core. And that the standard protocol was whatever you want to call it, whether it was, like, thank goodness she had that mindfulness practice, and then she noticed the eye movements, and then she got into her workshop and came up with this protocol, or you might think it was divinely inspired, or whatever it is. In the end, it's rather, to use Jamie's favorite word, it's elegant. And it is, and this is something I say all the time, it's structured, not rigid. And once one gets a handle on that, it's nice to have some structure when working with addiction.
And to that point, yes, I feel the 12 steps can provide this. I feel the EMDR protocol can provide this. It's a flexible structure. Because if you're so rigid in the structure, that can alienate a client. Yet having the structure, I believe, is important to do good work in this. Remember what I said earlier, that you need to learn how to break the rules elegantly when you need to. But if you don't learn the rules in the first place, you'll just come across as amateur. So that's really my feeling on making peace with the standard protocol. And I've written about that several places. And I think it's interesting, and I just want to reflect on this as a person in long-term recovery with addiction, with a dissociation, that when I do hear these questions about, well, what protocol do you use for this? I get concerned about the quick fix nature of those questions. Because for me, recovery has been anything but that. It's been anything but, well, it's going to be a one and done thing that will do it. It's something that's much more comprehensive, which is why Steve and I have really been trying to further this conversation, that in doing good EMDR work, having this strong grounding in the standard protocol is what's most important. So that is the official end of the workshop that will be available on the recording later. We just want to go over a couple logistics and a little bit of a commercial. So some people have asked if this workshop will be available for credits. In this free form, no, because you've not signed in, you've not done anything like that. What I like to do with a lot of our new material is make it available kind of as a pilot. So for those of you who attended the workshop today, who gave us your comments, this has been really helpful in how we're going to package this. So yes, this recording will be available for a week from today for free. So you can pass it along for free. There's no credits attached. And I'll also have a YouTube link up where you can access it for free. Then we're going to need a few weeks to get it together with some of these other resources. And at that point, it'll be available for a comprehensive course on the ICM site for 3 EMDRIA credits and some other CEs. So if you already watched the workshop today, basically you just sign up for the course. It'll be about a $45 fee, and then you take the test and you'll get your credits. So that's how we do a lot of our new content. Also in the coming weeks, we'll have up a complete EMDRIA 12 credit hour course to go along with the book course. We're still getting the approval on that. They're a little backlogged right now. So stay tuned to instituteforcreativemindfulness.com. You could sign up for our mailing list if you're not on it. You can also stay tuned to the Facebook page, and I post these announcements as they come and in the groups. Thanks for bearing with us on the technical struggle today. I think we managed to figure it out though. And as a reminder, Healing Addiction with EMDR Therapy is now out from Springer Publishing. This is the basis of a lot of our conversation today in this workshop. And if you want more of this content, consider getting the book and maybe taking the 12-hour version of the course instead of this 3-hour one. Thanks to all of you for the beautiful comments that are coming through. Keep working from that place of just knowing good EMDR. And we're sure you'll have success in this area too, as long as you be an open vessel to learning, right?
Thank you for everything that you have done and you will do in ending some suffering on this crazy planet.